Good morning. I'm John Iglehart, the founding editor of Health Affairs, and I'll moderate this morning's discussion, and I'm delighted to see the room full. We had something like 265 RSVPs, and we weren't certain where we were going to put them all, so be glad you have a seat. Anyway, in terms, we've left a lot of room for Q&A, assuming this audience will have a lot of questions of the speakers. But I ask that when you have a question or a comment that you wait until you get a microphone, because we do have people on a live webcast who will also have an opportunity to ask questions. Identify yourself, if you would, and the organization that you represent, assuming you represent one, and we'll take your questions. It's a particular pleasure to introduce Dr. George Thibault, who is the president, seventh president, actually, of the Josiah Macy Jr. Foundation, which is a New York City-based foundation that's done a lot of work over the years in medical education and in GME, and particularly appreciative of Macy's involvement because they provided the support to enable us to do this briefing, which really is the first opportunity that the broad community has had to at least react publicly to the IOM GME report, which obviously is the subject of this morning. The report was released on July 29th, several days before Congress took its long August break, and so there really hasn't been an opportunity for a public forum to really articulate views on this very important subject. So with that, I'll turn it over for a few minutes to Dr. Thibault, and we'll move on to our program.
Thanks, John, and thanks to Health Affairs for putting on this important forum, and thank the audience for being here to acknowledge how important this issue is. On a personal note, let me say, prior to becoming president of the Macy Foundation 7 years ago, I spent my whole career at Harvard and its affiliated hospitals immersed in GME. I spent a decade as a program director in internal medicine, nearly a decade as a chief of medicine, more than a decade as a chief medical officer of first an academic medical center and then an academic healthcare system with oversight responsibility for some of the largest GME programs in the country. And I personally taught in GME programs throughout that time. So I come to this subject with a very personal set of experiences. Now, GME, as we know it in this country, is a relatively new phenomenon. It's really a post-World War II phenomenon. And it's grown tremendously. And, of course, it is tremendously important because it is, in fact, what determines the composition of our physician workforce in this country, by and large. Now, in every decade since the 50s, there have been calls for reform of GME. This is a recurrent topic. There have been long-standing concerns about the stability, amount, and source of funding of GME, about issues of governance and accountability, about the content of GME and the balance between service and learning, and about the geographic distribution and specialty distribution of physicians. These are not new issues. The Macy Foundation has been involved in that dialogue over the decades. In 1980, it issued a report called A Call for Action, in which it called for greater medical school oversight of GME. And it also called for alternative funding mechanism, particularly for primary care. In 1992, the Macy Foundation issued another report called Meeting the Needs for the 21st Century, in which it called for a public-private federal commission to set policy and to allocate positions. And it also called for more innovation in GME. In 2010, 2011, the Macy Foundation held 2 conferences, issued 2 reports that really directly led to this IOM study. Among other things, those reports called for greater accountability of the system, called for new content, new sites, and greater efficiency in the GME training process. It also called for interdisciplinary and interprofessional education, and it called for more research on GME. Now, this present report addresses many of the issues of these past reports, and it also breaks new ground. It is very well written. I urge everybody to read it in detail because it cogently makes the case of why our GME system must be improved to meet the changing needs of a society with changing demography, changing disease burden, and also a changing healthcare system. I would say it breaks new ground in a few notable ways. One, I would say it is remarkable, and I don't think has been sufficiently celebrated, that a commission chaired by two former heads of CMS, one in a Republican administration, one in a Democratic administration, reaffirmed the importance of Medicare continued funding of GME at the present level. Many economists and policymakers have been arguing exactly opposite that. So that is actually profoundly important and I think insufficiently celebrated. It also breaks new ground by suggesting that this distinction between DME and IME be done away with and that it'll be one pot of money. IME has been always poorly understood, and it's always been a target for budget cutting. That is important new ground, that concept. It also goes beyond calling for accountability by actually suggesting a mechanism of accountability by setting up a GME policy council and suggesting moving gradually to a pay-for-performance system of payment with public reporting that in many ways mirrors what's going on in the healthcare delivery system. And it also calls for a 10-year process to phase in these changes because they are so complicated and so potentially disruptive. Now, because they are complicated and potentially disruptive and because there's a lot of money involved, not surprisingly, this has already generated controversy. But I would hope that this could be the basis of a discussion going forward. I'm sure everybody that's worked so hard on the report would be the first to acknowledge that they don't necessarily think they got it all right. There's more work to be done. And before we start counting winners and losers in this, I would suggest that we engage together, all stakeholders, in a dialogue about how we can improve the GME system to meet the needs of the public. And I would suggest that there are 5 goals that we should have for that improved GME system. The first is that we do need stable funding. We need assured stable funding that's not subject to year-to-year threats. And there needs to be some way that that funding could increase if there's demonstrated need and purpose. Secondly, we need to align GME with a changing delivery system. Things are changing so dramatically in the delivery system. It would be amazing if we didn't need to change the system that prepares people to go into the delivery system when it's changing so much. Along those lines, we need a system that encourages and promotes innovation, but also has a mechanism for evaluating those innovations. And we need a system that better meets the needs of the public by geographic distribution and specialty distribution, acknowledging that the GME system alone doesn't determine those things. And finally, we do need a system that's more accountable with public reporting and more transparency, which in fact is consistent with everything else we're doing in our society today. So I hope that this discussion has begun and that the academic medical centers of our country, which are so important and so essential, and we will not have these changes without the leadership of academic medical centers, that they'll be fully engaged in these discussions. I am very confident that with the talent, resources, and leadership of academic medicine today, academic medical centers can and will thrive in a reformed GME system. And I'll conclude by quoting from the report and introducing the recommendations. The report says, "This is the time for all engaged in GME to work together to provide the physician workforce that the country needs." Thank you very much. I'm looking forward to the discussion today.
Well, our first speaker after George is Gail Wilensky, an economist and a senior fellow at Project Hope, which also happens to be the publisher of Health Affairs. But Gail is a well-known figure in the policy realm. She was administrator of the Healthcare Financing Administration, first chair of the Medicare Payment Advisory Commission, and has held a host of other jobs and responsibilities over the years, and of course was a co-chair of the report today. So with that, I won't go on to her long CV. Take that time. We'll let her take over. Gail?
Thank you. It's a pleasure to be here representing the committee, which, as John indicated, I had co-chaired. George described well, I believe, the context in which we on the committee viewed our charge, and also indicated, I was glad to see, some of the issues which we struggled with and came out in an affirmative way, particularly with regard to continuing the current amount of Medicare funding for GME for at least the next decade, while the recommendations that we have made or recommendations similar to the ones that we have made could be carried out. So what I'd like to do with the few minutes that I have before we get into the panels is to indicate the context in which we viewed these issues, and then very quickly summarize the recommendations, although George indicated already the most important. We regarded our charge as helping to develop a workforce that would be likely to meet the needs of the American public as the driving force with which we viewed both current GME and any of the changes to GME that we might consider. We regarded that the current system is resulting in a mismatch between the healthcare needs of the population and particularly the specialty, the highly specialized nature of the physician workforce. We noted, as many before us have noted, the persistent geographic maldistribution of physicians. That's not limited to the U.S. That is a worldwide issue of note. Concerns about insufficient diversity of the physician population, although better than it has been in the past decades, and the discrepancies between what physicians end up knowing and what they need to know in order to be able to take care of in a competent way their medical practices, and the lack of fiscal transparency, which we felt, given the very unusual role that the federal government has played in funding GME, was particularly an issue. We debated for a long time. In fact, I believe the issue arose at every session that we had over the 18 or 19 months of deliberation of the committee, why exactly the federal government is or should continue in this role of putting in approximately $15 billion in graduate medical education, $10 billion of which comes through the Medicare program, Medicaid being the other largest funder, given the lack of a comparable role in either undergraduate medical education or in other healthcare professions or in other professions which are important to society and in short supply. And while I think it is fair to say why we agreed to recommend a continued funding for at least the next decade probably differed for different members of the committee, we felt that the changing delivery system, which the country is now undergoing, could be so much helped by continuing federal support, training the physicians that are coming forward now to better meet the needs of the 21st century than what has happened in the past, that was a sufficient justification to recommend continued Medicare funding with inflation adjustment for at least the next decade, after which we recommended that this issue be reconsidered as to whether or not there was continuing role for the federal government going forward, and if so, what that role might be. We also, in looking at the issues that we were asked to, recognized that as important as graduate medical education is, it is not sufficient to produce the kind of changes that I've just noted, that George has noted with regard to the specialty distribution, the geographic distribution, other issues with regard to the physician workforce, that how reimbursements are set, both in the public and the private sector, that the ability to have loan forgiveness or other targeted programs and other issues will be much more important in terms of addressing this issue, but that we felt graduate medical education could be supportive of helping to train the kind of physicians that would be needed for a 21st century delivery system, and that at present that was not going on. And it was really within that context that we brought together our 21 very diverse thinkers, a simple majority of whom were physicians, many of whom have had very long-standing involvements in graduate medical education, as was the case for a number of the people on the commission who were not physicians, who have also had long-standing involvement with regard to graduate medical education. Our findings were that the ability to predict our future needs in any clear way with regard to either in total or by specialty has been very weak. We think that it happens for a variety of reasons, but it's particularly an issue now because we are in the midst of this changing delivery system. And the productivity of physicians depends so much on the context in which they are working, the delivery system in which they work, but also who else joins them as part of the healthcare team, which has been such an important part of the discussion. And that we therefore did not regard it as useful for us to talk about whether or not 10 or 20 years out in the future we are likely to have a shortage, and if so, of what magnitude and what specialties, because we had noted they had been so wrong in the past, sometimes even directionally wrong. But that what we wanted to try to recommend was a structure that would be more flexible and responsive and be able to respond to needs as they changed, which we regarded as not characterizing the existing graduate medical education workforce. We also noted that the number of physicians being trained, as well as the number of people in medical schools, seems quite independent of the federal money that is being put into the system. There has been a substantial increase in the number of medical schools, a number just opening in the last year, for example, and the number of slots in medical schools, and in the number of residency positions that have occurred since the Medicare cap went in place with the Balanced Budget Act, although there's been some modest, very minor changes since the 1996 Balanced Budget Act. We've had 5 recommendations. 4 of them are somewhat more complicated. The fifth, which involves Medicaid, is the simplest, which is keep it a state option. But the kind of transparency issues that we have raised as being important for the use of Medicare monies for recommendations 1 through 4 ought to apply for Medicaid as well. In brief, because I know a number of these issues will come up in the later panels, what we have recommended is that we maintain the current amount, as I've indicated, indexed for inflation, that we look at graduate medical education in a combined way, as George had mentioned, that we no longer continue these 2 funding streams, direct and indirect medical education, which came up after the prospective payment system was introduced in 1983, but rather move to a single funding stream, that over time, as the metrics are available, we have a performance-based system. That we put in place a GME policy and financing infrastructure, which we don't believe exists. The Policy Council that we've recommended, which has at least a relationship to MedPAC in terms of how we have thought about it. That is a mix of experts representing different policy areas, a minority of whom can be involved as stakeholders, but no more than a minority, be placed in the Secretary's office to help make recommendations about areas of study that are needed, et cetera, that it be appropriately financed, and that there be a GME center within CMS that would actually be responsible for distributing the funds in a way that's consistent with regard to the policies that this Policy Council makes. That we have a single GME fund with two subsidiary funds. One's an operational fund, and that operational fund, which will always represent the bulk of the money, be where funding for residents occurs. But there be a very important second fund called the Transformation Fund, which will be used to finance innovations, both in terms of how the money is distributed, but also in terms of developing some of the various metrics and research that needs to occur. That is likely to represent smaller dollars because research typically does relative to actually doing pilot studies, but extremely important work in terms of helping to develop performance-based metrics or helping to assess some of the educational strategies that are going to be undertaken. To change the GME payment methodology, to go to this single payment, to start with the existing number of Medicare-funded slots, to distribute the bulk of the money. We're assuming initially about 90% over those existing slots, to go to a single per resident amount with a geographic adjustment. And to begin to build up the amount of money that is available for the Transformation Fund over several years as the infrastructure is developed in order to try to appropriately use that kind of funding, and to have the information then feed back into the Operation Fund as it is available. So as there's shifting of funds initially over to the Transformation Fund and then back into the Operation Fund as the metrics are developed and this is ready to be folded into the program. As George indicated, we are recommending some significant changes. We recognize that institutions need some time to adjust, which is why we've thought about this as appropriately occurring over the course of a decade. It's why we also thought it important at the end of approximately a decade that there be a reassessment of where we are and whether or not this was an appropriate way to go forward, including asking again the fundamental question about why is the federal government in this, and is it appropriate to continue, and if so, at approximately the current level or some other level. We tried not to prejudge the answer to that, that it would either be too much or too little. But again, it was the view of being able to think about Medicare money as jump-starting the training process for graduate medical education to help develop a workforce that would be better suited to meet the needs of 21st century delivery systems, that unified this very disparate committee into making what we also regarded as a bold statement at the current time, which was to continue the current amount of Medicare funding indexed for inflation going forward for the next decade, not something that has always been assumed such committees would recommend. So we recognize both the amount of change we're suggesting, but we hope that we will have the full set of recommendations given the serious consideration that we think they deserve. Thank you.
And we'll turn to Thomas Nasca, who is our next speaker. He is the Chief Executive Officer of the Accreditation Council for Graduate Medical Education, a post he has held for 7 years. Tom spent much of his career at Thomas Jefferson University, Dean of the Medical School, senior executives in other posts, and a distinguished figure for certain in the GME world. Tom?
Well, thanks, John. And, for those of you who don't know some of the lexicon of the alphabet soup of medical organizations, the ACGME stands for the Accreditation Council for Graduate Medical Education. It is the accreditor for residency and fellowship training in the United States. And inside the profession, it sort of goes like this. Hi, I'm from the ACGME, and I come from Washington. I'm really the IRS, and I'm here to help you. That's the way most people feel about the ACGME. What I'd like to do is set a frame for you. Accreditation is a necessary but not sufficient vehicle for transforming graduate medical education. So it sets the frame within which graduate medical education occurs, but it does not necessarily direct all dimensions of that frame. So the frame can move in lots of different ways based on external factors outside the accreditation process. What I'd like to do is sort of outline for you a number of the areas of change in accreditation that's occurred over the last 5 years in graduate medical education that are really consistent with the recommendations not only of the IOM committee but also the Macy Foundation reports that George alluded to a little while ago. The first is the next accreditation system. We've really moved to a model of continuous accreditation. So there's annual accreditation that occurs of all of the 9,300 residency programs and fellowship programs in the United States, covering 121,000 residents and fellows. That's 1 out of every 7 doctors in the United States are in an ACGME accredited training program at the present time. It's really designed to promote innovation, and in the questions and answers we can talk about how you can use an accreditation tool to promote innovation. We've reduced process standards, and we've really moved towards looking at educational outcomes, and that leads to the second change, that is the Milestones Project. We've worked with the certifying boards, with the colleges, with the residency program directors, and with residents to define the logical developmental steps in every specialty and subspecialty. We accredit 141 different disciplines. And each one of those disciplines now have a set of milestones, educational outcomes, that are behaviorally described and able to be measured, and we indeed report those and track those outcomes every 6 months in every one of those 121,000 residents and fellows now. The clinical learning environment review, some of you may have heard about this, is a unique, in accreditation speak, kind of a process because it does not involve accreditation. The only requirement that an institution, a sponsoring institution must have is that they must have a clear visit. It is a group of experts who come into the learning environment and assess the learning environment writ large, because we believe that has a dramatic influence on the quality and effectiveness of the physician after they graduate from the residency program. And that is not gleamable by looking just at the individual residency program. And it specifically assesses a number of very important areas to society, and that is quality and safety, reduction in disparities, and the professionalism that with which the residents are indeed educated, because they carry that posture with them throughout their life of service. You may have heard that ACGME, the American Osteopathic Association, and the Association of American Osteopathic Medical Schools have come to an agreement to merge osteopathic accreditation and allopathic accreditation. That process will culminate in the election of board members and the beginning of the process of accrediting all of the osteopathic programs and the allopathic programs with a single set of standards. So we will have one graduate medical education system in the United States starting in July of 2015, and my colleagues from the osteopathic community are in the audience as well. We have a number of research efforts. Those of you who have read previous IOM reports have seen the ACGME called to task for a number of reasons. Even they don't like the IRS. And one of them related to duty hours and the understanding of the impact of fatigue in the learning environment on not only on patient care but also education. And we're funding two large multi-center trials that are actually underway right now, looking at educational and clinical outcomes with variations of some of our existing duty hour standards, with an eye towards using research in the next modification of the duty hour standards. We're in the midst of conducting with our certifying colleagues validation of the milestones, because the milestone framework, this developmental framework, is an experimental model. And we are deep in the process of validating those milestones and modifying them where they need to be modified. And then this last bullet, I think, is fundamentally important in the long term in accomplishing the goal of having our graduate medical education meet the public need, and that is really understanding the nature of the linkage between the clinical learning environment and clinical outcomes of patients under the care of residents after they graduate. And that research is going on, not only sponsored by ACGME and conducted by ACGME, but other investigators in the field. And then we really do believe that it's time for the accreditors to start to get together and have a common way of looking at some of these problems, because these problems, as the IOM report points out, and many have pointed out, these are not just graduate medical education issues. They are healthcare delivery issues that involve all professionals on the team. Now, we just embarked on and completed a two-year strategic planning process, and it was enlightening for us to see that the IOM came to some similar conclusions and had some similar insights about the future. And I just want to point out a couple of them because they have implications for our discussions today. The number and mix of physicians required is really highly dependent on unpredictable circumstances. And the reason for this is that the physician pipeline is a long pipeline. It takes many years to produce a physician, 4 years of medical school, a minimum of 3 years of residency. On average, graduate medical education training is 4.3 years. So that's a 7-year window. If you add in pre-medical education and then the first career opportunity, we're really talking about a decade to really change the direction of a ship of delivery. It takes a long time in order to do this. And we don't know what we don't know because the future is that unpredictable, especially in the clinical care environment where the system is unstable. It's going in a new direction, and we're not sure where that direction is going to take us. We do know that interprofessional care teams will be an increasing phenomenon in the future, but we don't know where and to what extent that will happen. We do believe, however, that commoditization of physician services will have a dramatic impact on the careers of physicians. The physicians we graduate from residency in June of this next year will be practicing in 2050. I don't think any of us in this room have any understanding of what that world will look like. Yet these physicians need to be prepared to practice in that environment. And we believe that, and I think this is underrepresented, although George alluded to this, and so did Dr. Wilensky, and that is that hospitals, while we do need to shift training from hospitals in a number of disciplines, or some proportion of their training from hospitals in a number of disciplines, hospitals are an essential element. They're the organizing unit of graduate medical education. And in the absence of another organizing unit, the hospitals must maintain their presence. They support significant infrastructure in graduate medical education that cannot be borne by individual programs. What are some examples of that? Well, the computer systems that residency evaluation are conducted on, and the computer infrastructure for some of those tools is a shared data infrastructure across an institution. No individual program could afford that kind of infrastructure. Simulation technology, which is increasingly important in all fields, not just in the technical fields, the manual technical fields, is fundamentally important and increasingly driven by standards as a requirement, and it is very expensive. And it needs to be shared. It's a shared resource. It can't be borne by a single individual program or small subspecialty program. So the implications of these insights are that career flexibility for physicians is fundamentally important. And many of the things that have happened in the last 20 years with regard to accreditation, certification, and the pipeline have made that flexibility less possible. They're increasingly rigid barriers or silos that physicians are produced in, and we need to redesign the system to produce a more flexible opportunity for physicians to move as their specialty needs change or the public need changes. The educational systems, therefore, must be more nimble, and I think you heard that from both of our speakers before. And then collaboration among the accreditors is imperative. If we don't get together, we're going to be going in multiple directions, all trying to do the same thing, yet producing conflict on the ground, which will be duplicative and very cost inefficient, as well as frustrating. So with that, I'd like to thank you, and I'll be glad to answer questions during the panel.
Thank you, Tom. We'll move on to Steve Lipstein, our next speaker on this panel. Steve is Chief Executive Officer of the BJC healthcare system in St. Louis, really one of the largest healthcare systems in the country, 26,000 employees, $4 billion in net revenue, et cetera. He's also on the board of the Washington University. He's vice chair of PCORI. He's a busy man. Steve?
Yeah, good morning. And thank you for having me today and the opportunity to serve on this panel. When I read the IAOM report on GME that we're talking about this morning, I instantly felt that I had read some of this report before. And as Dr. Thibault mentioned in his introductory remarks, just a sidelight, Dr. Thibault and I go back all the way to Massachusetts General Hospital together. The two of us were the power forwards on the MGH basketball team. I went to the shelf. I went to my shelf and I pulled off this copy of the Commonwealth Fund Task Force on Academic Health Centers. It was a report of the task force in 1985. It was written from 1982 to 1985, and in this report, there were three reports actually. One was written on graduate medical education, and the consulting author on that was Steve Schroeder. One was written on care of the poor and the uninsured. The consulting author there was Larry Lewin. And one was written on the future financing of teaching hospitals, and the consulting author there was Jerry Anderson. And these are names that I'm sure you know. But I want to read just, and by the way, the reason I have the only copy that's still in print is that as you can see, I was the assistant program director for this task force, and it was a much younger version of me. But the report leads off with, and forgive me for reading, but it's just interesting. The American system of medical care is undergoing revolutionary changes. Its funding and organization are being dramatically altered. The sweep of these changes threatens the crucial triad of functions that the nation's academic health centers provide: medical education, research, and patient care. I got to keep going here for just a little bit. The task force report on graduate medical education, Dr. Wilensky, we're back in 1982 now. The task force report on graduate medical education outlines in detail the system of residency training in this country and describes the multiple organizations that influence the size, content, and length of such graduate programs. The report finds that none of these organizations has a proper relationship to the financing of graduate medical education, and none takes real responsibility for the overall size or cost of graduate medical education. The report makes specific recommendations. The task force report on health care for the poor and the uninsured identified the significant role that teaching hospitals play and finds wide-ranging diversity among teaching hospitals in terms of the amount of uncompensated care they render. The problem of uncompensated care threatens many major teaching hospitals and creates a real and growing problem for the access of the uninsured to needed medical care. The task force finds that the problem of uncompensated care can only grow worse in a price-competitive system of medical care. The report calls for concerted action, especially by government, to resolve the problem. And the final task force report on the future financing of teaching hospitals finds that the Medicare DRG system does not adequately compensate these hospitals for their special patient care responsibilities. As Medicare payments for education are reduced, the ability of teaching hospitals to offer sophisticated medical services and care for the poor are severely diminished. The task force recommends changes in the reimbursement system for teaching hospitals. Finally, and since I helped author this paragraph and it's very bold, I'll apologize in advance. The task force wants to underline that its recommendations are aimed at preserving the functions of academic health centers that are essential to society. The task force fully recognizes that academic health centers must adjust to changing circumstances in society. However, these changes must preserve society's vital interests in retaining the most technologically advanced and most effective system of medical education. We went out on a limb there, I grant you. Research and patient care in the world. The reason I wanted to share that is one of the things I learned from my experience back in 1982 is when you talk about GME, when we talk about changes to GME, the context within which those changes takes place is very important. And so as my contribution to the panel discussion this morning, I just wanted to provide a little bit of that context for what's happening, not just to teaching hospitals, but what's happening to the training environment in which residents and students are now learning, as well as a little bit of the context of where we're going as a country. And so I'm going to take you on a journey. This is a picture of Mount Everest. I took this picture, and I'm going to talk to you, but I want you to imagine at the summit of this mountain is the triple aim times 2. The first triple aim, as you know, is to improve health care, quality, safety, and patient outcomes, to improve the population's health, and to lower per capita costs. The second triple aim at the top of this summit is the triple aim of academic medicine, which is to provide patient care at the highest order, to educate the next generation of healthcare professionals, and to do medical research, to advance medical science and technology and information and just knowledge about human health and how we can improve it. So now we're going to go up this journey. I'm going to take you on a really quick journey because they only give me 5 minutes to climb to the top of Mount Everest. But we're going to go on a really quick journey so that I can share with you what's happening. But before we go up, we need people to guide us up the mountain. And so I'm just showing you a picture of our 3 Sherpas who took us to Everest Base Camp a couple of years ago. The person on the right is the full professor, the person who's been up to the summit of Mount Everest 7 times, and he's teaching the rest of us. The person in the upper left is your fellow, Gail Sherpa, and he's the one who's in training to take future generations of trekkers up to the summit. And then the person all the way to the left is the person that's going to give us all of our provisions, all of our food. He carries our oxygen if we need it. He also takes care of all the other provisions. We need Sherpas to guide us on this journey to the summit of the triple aim times 2, and I'm going to talk a little bit about that in just a minute. So let's start our journey to this triple aim at the top, because this is the context within which graduate medical education is taking place today. And we're going to start at base camp. And you can see we have 2 wonderful Sherpas who are going to start us on this journey from base camp. And the first thing we know we come in contact with is the stimulus bill, which requires all hospitals and doctors to become meaningful users of health information technology, which is dramatically changing graduate medical education in the United States. The use of technology on rounds today just makes it very different from when I went on rounds 30 years ago. And when you look at the technology and the technological capability of today's medical students and residents, it's just a little bit more advanced than where we used to be. The other thing you should know about this is that becoming meaningful users of health information technology is using up some oxygen. It's very expensive. And so as we think about how we're financing the hospitals in our nation on this journey to the summit, we're just using a little bit more of the oxygen available to these hospitals as we go higher up. Then, as you know, the Affordable Care Act, all we need to say about the Affordable Care Act in this context is that we took oxygen out of the Medicare tanks and we were going to move it to the Medicaid expansion tanks, and we were going to move it to the tanks associated with subsidizing health insurance that people would buy at the exchanges. And it's just a fact that 23 states have not yet purchased the Medicaid expansion tanks. And so we did take some oxygen out of the Medicare tanks. And so as we talk about GME, at least in those 23 states that did not expand Medicaid, it's a contributing factor to our context of how we evaluate these recommendations. Then we go up another, we're getting up higher, and as you know, the Budget Control Act of 2011, the sequester, took some additional oxygen out of the Medicare tanks. And then you know that we have the Taxpayer Relief Act, which had in it some coding offsets for the way we code DRGs and how we offset, and that took some additional oxygen out of the Medicare oxygen tanks. So what I'm trying to say is, as we're talking about reforming GME and we're going higher and higher towards the summit, all of which we agree are good things to do, important things to do, it's just getting a little harder to breathe, okay? And we're moving oxygen around among the tanks. So now we get a little bit higher up, and we know that as we have new Sherpas guiding us up the mountain, and these Sherpas are wonderful people, by the way. They are wonderful people. They are important people in the dialogue. But one of the things I want you to notice is that the Sherpas change the higher up we go. And that's an important thing for us to consider as we have our discussion later this morning. But we are going to take oxygen out of the fee-for-service tanks, and we want to move them to the pay-for-performance tanks. And we think that's a good thing in helping us to get to our triple aim. But then we're not going to stop there. We want to take the oxygen out of the pay-for-performance tanks and move it to the Medicare Shared Savings Program tanks. And then we want to even go a little bit higher up, and we want to take oxygen out of the shared savings tanks and put it into full capitation, full risk tanks, or what we call Medicare Advantage. And I give you examples there on the slide. In the interest of time, I won't read it. But one of the things that we then get to the, as we pursue this triple aim, we get higher up on the mountain, and now we're going to move the oxygen again. And these are some of the most important recommendations that are in the IOM GME report, which is that in order to get the kind of GME system we want to move oxygen from the current GME tanks to new oxygen tanks. And we'll talk about that in just a minute. So how does this story end? Because we're going on a very quick journey. Well, it can end happily ever after. This is a picture of our son, the one you saw 2 slides back, down on one knee proposing to our daughter-in-law at the top of Kilimanjaro. She is altitude sick. So she says yes because she just wants to get off the mountain in a hurry. But they do live happily ever after. And there are teaching hospitals, there are hospitals in general right now that are prospering in this journey to the summit. But it's pretty predictable who they are, and it's important to our context. So, for example, hospitals that are located in affluent communities are doing pretty well on this journey right now. And teaching hospitals who went up this journey with a fair amount of oxygen in reserve, think of it as reserve oxygen tanks or cash reserves, are going to be able to adapt to this transformation journey that we want to take as it relates to GME. And then there are other teaching hospitals that live in jurisdictions with a very, very deep local tax base. So if your local tax base can support safety net care or care for the uninsured, and I want you to think of community, I'll mention the hospital. So you've got Grady Memorial, or you've got Parkland, or you've got Denver Health, or you've got Cook County. You've got some jurisdictions out there that have really deep tax bases that can support a local safety net. But that's not the circumstance across the entire United States. There are jurisdictions that are that don't have the ability to tax themselves to support a safety net. And so the other alternative here, and this is a monument in Farice. This is a picture I took this is where the Himalayan Rescue Squad is. And engraved on the inside of this monument are the names of people who attempted to summit Mount Everest and died. And they didn't die going up. They actually died. Many of them get to the summit, they have a summit date, and they die on the way down because there's just not enough oxygen to sustain them at that level and help them get back down the mountain. And so the kinds of hospitals that are likely to end up on this monument, they're also very predictable right now. So in the states that aren't taking the Medicaid expansion, the rural hospitals are struggling mightily right now. They're having real trouble breathing because they get most of their revenues from Medicare and Medicaid, and they take care of a lot of uninsured people, and the median income in many of these rural communities is already below, is around $32,000 to $34,000 a year. So we already know that there are hospitals out there that are really having difficulty breathing. The teaching hospitals that exist in jurisdictions that don't have a deep tax base, okay, think of North Philadelphia, East St. Louis, East Baltimore, the south side of Chicago. There are teaching hospitals that live in jurisdictions that are really going to have trouble generating some oxygen here to go on this transformation journey that we're talking about. And then there are also just the hospitals and the teaching hospitals that are going in this with no reserve oxygen. They just don't have the tanks to get through this journey in a meaningful way. So as we look at these recommendations that Gail described in her remarks very well, the first thing I want you to kind of take away is in the American healthcare system right now, as it affects graduate medical education and the mission of teaching hospitals and medical school, just know that we are moving a lot of oxygen around. We are moving it from one tank to another in pursuit of our 2 triple aims. And when you move this much oxygen around at one time, you have to ask yourself, who is responsible for the overall oxygenation of the system or the oxygenation of the patient? And there are some patients that are going to struggle, and there are some patients that aren't going to struggle. But we have to be mindful of that as we go on this transformation journey. So the questions I ask, because we went on this journey in the 1980s, is not just what are the recommendations that are coming out of the IOM report, but who's going to guide us up the mountain? Who are the Sherpas of the future going to be that are going to take us to this GME transformational place, and how long are they going to stay on the mountain? That how long they stay on the mountain is really important because, as Dr. Wilensky said, this is going to take a long time to do and a long time to get right. And one of the concerns I have about positioning the responsibility for this in CMS or HHS is, as good as those Sherpas are, as good as those guides are in helping us get up the mountain, how long are they going to stay, and can they see the process through from beginning to end? Because the consistency of that leadership becomes really important. Obviously, teaching hospitals, because of how diverse and heterogeneous the United States is, are concerned about their sources of oxygen as we go through just enormous transformation in the American healthcare system right now. And then finally, we need to find experienced people to do this. As we find the people who are going to evaluate this IOM report, extract from it what we can and cannot do, but what we can do, it's important that we find people who have been on this mountain before. I personally have never been to 29,000 feet, and I'm afraid of heights. Okay? But we do need people who have been above base camp before, and importantly, who have done this at scale. We can't just find people who have run one training program in one specialty area, in one teaching hospital, in one market in the United States. The country is just way too big and way too diverse for those people who have that sole specialty experience to be able to take their knowledge to scale in a country this diverse. I look forward to our questions, our discussion. Thank you for having me today.
Well, the schedule says we have 5 minutes before we have a break, but I'll extend that to 10 minutes. And since Steve broached at the very end the question about where you put the Sherpas, I'll ask Gail the first question about why the committee decided, particularly given your experience, Gail, as chair of the MedPAC and knowing its influence over many years, why the committee decided to house the structure within the department rather than in some other place.
Thank you. We had many discussions on that basis, on that question, as you might imagine, and considered both inside versus outside government or somewhere in between as MedPAC. We spoke with many people who are currently or previously been on the Hill or in government, and including our friends at MedPAC who had to struggle through some of these same issues about the desirability of inside government, outside government, somewhere in between, but outside the department. At the end of the day, we thought having this entity inside HHS, but higher up than it has existed in the past, therefore in the Office of the Secretary, to set policy goals and research agendas that would then be operationally carried out to the extent that we are talking about the distribution of Medicare monies by a GME center within CMS, but also involving many outside organization and linkages to the people, the usual suspects, so to speak, was the best combination of not creating new entities, to put greater strength in and changing existing structure, to move it up higher in the organization, and that on balance it represented, we believed, the best structure we could think about. But we want to be very careful about what we aren't recommending, because we've noticed some confusion. All of the activities that go on by the outside groups now will continue to have their functions, including the accreditation, which we think is not only very important for the accreditation purposes that it obviously controls, but for the importance of better coordination across these accreditation, and with trying to have as much consistency between the accreditation process and the other activities as is possible. That there will be the creation of new residency programs and medical schools as they've gone on in the past, and all of the functions that have gone on in the past are allowed to continue. We are not giving an authority over the creation of new residency programs to the government. There was definitely some confusion by people who had read the early versions of the report about what we weren't and weren't not creating in government. So all of the ability to create new programs, new medical schools, new residency programs will go on. What we are trying to make more rational and coherent is oversight over public money, which we think is very important to occur, and to put it in a strengthened position. And, oh, by the way, MedPAC didn't really want this function because we asked.
Questions? Yeah. Would you identify yourself? Please stand up so we can hear you and ask your question briefly, please.
Joel Coopersmith from Georgetown University. Two parts. One is making the system simpler and bringing it to public attention has the disadvantage of making it a target. And I wonder what you think of the public support in this area is at this point. Secondly, the other major government player here is the VA, which I don't think is part of this program, but one can envision it's crucial to many universities, many programs, and one can envision many things happening to that. Particularly if the VA begins to focus, and I don't know if this is going to happen, but one of the things that seems like the VA may focus more on post-deployment conditions, which will alter the kind of training it can give. 100 other things could happen to the VA that affect this. So it's an important piece to remember.
Joe, you're correct that making it clear to the public how much money is being spent and how it's being spent may raise questions. My attitude is that this is the public's money. They're entitled to understand, to make it transparent and accountable. We think it has not been in terms of meeting public needs. I don't mean accountable in terms of meeting the specifics of Medicare law. I mean in terms of supporting the needs of the American public. If it means that if the public actually understood where its money was going, they would not support its use. This being a democracy, it ought to be able to make bad decisions if it so chooses. So it's always a risk, but I regard that as an improvement and an important addition. We talked about the VA, and as you probably know, the VA provided some financial support, and we had the VA come talk to us. But we recognize that both the VA and the DoD systems have been important, not just in terms of the role of training new physicians, the VA more important in that role because of its ties with academic health centers. But we thought that was taking us into an area that we had not focused on. Some of us on the committee have spent time working with the VA. Some people have joint appointments with the VA that were on our committee, but the committee did not itself look at these issues and weren't asked to look at these issues, and so we thought it appropriate not to go into that in terms of our recommendations specifically.
Steve?
I would just to offer up a different perspective. I've had two professional experiences that kind of inform this opinion. One is I served for a full term on the board of the St. Louis Federal Reserve Bank. And then I'm also currently serving as the vice chair of the Patient-Centered Outcomes Research Institute. And these are two instruments, if you will, that were created by government but are outside of government. And in creating them outside of government, they're distributed across the United States. There's actually 12 districts of the Federal Reserve across the United States, and there are, and PCORI actually, our board conducted all of its board meetings on the road for the first 2 years. And what you learn by traveling out there is you can engender public trust. I hate to say this, but you can engender public trust just by being out of this city. And the idea that you go to the people with graduate medical education policy, or you go to the people with monetary policy, or you go to the people with explaining, comparative clinical effectiveness research, you get a different level of engagement. And so the idea that if there were a way to make this GME transformation journey more local, more geographically distributed, and less concentrated in government, and I'm not an anti-government person. I believe it's government of the people, by the people, and for the people. It's a good thing, and I think Dr. Wilensky is exactly right. We need to be sure there's accountability for public dollars. Your only vehicle to do that can't just be CMS and HHS and MedPAC, because they're all associated with centralization and a political process, as opposed to something that really, really has its grassroots in transforming GME at a more regional, local level.
I think there is we would not regard this as an inappropriate issue to re-raise. We were concerned it would make it unlikely you would have Medicare funds in your outside activity, which we also discussed at length because there are obvious questions about why Medicare, and we ended up with a very practical position because there's nothing like entitlement funding for stability. So we would encourage that issue to be continued to be discussed. We think there are some dangers, but we think there are some obvious attractions, and we would not regard that in any way as a deal breaker. It was not where we thought, on balance, it was safest to house this.
And acknowledging that I'm much less schooled in how entitlements and Medicare funding would work. So, Tom?
I would just underscore the importance of the VA, though, in the graduate medical education effort. 40% of the residents in the United States receive some of their training at the VA. It's fundamentally important to the nation's graduate medical education effort.
Okay. Last question before we take a break. Way back in the... Get a mic and...
So thank you very much. I'm Sean Martin with the American Academy of Family Physicians, and I have a question regarding some provisions in the IOM report, which clearly questions, if you will, or articulates that care delivery has moved rapidly since 1965 out of the acute-based hospital setting. In fact, it continues to do so today. Yet we often view GME finances as a revenue stream for hospitals. So I'm curious your thoughts on the IOM recommendation that maybe we decouple or GME funding from the hospital, and what would that look like in your opinions?
I didn't emphasize in my comments, but it is clearer in the report and in a number of the summary statements that we are recommending that the recipient of the money be the sponsoring organization, which may be, and in many cases will be, academic health centers, but not necessarily only academic health centers, particularly in those areas where you are seeing groups of ambulatory care settings or the health centers or other groups that have been or that would be willing, if they could put a consortium together outside of the hospital, have an approved residency program, be the sponsoring organization. As you noted, we recognize that a lot of care is outside of the hospital. We think one of the reasons that you are seeing physicians who aren't as well prepared as they may be to take care of the patient is because they're not having enough of that training where care is actually provided outside of the hospital. And the funding flows don't prohibit it, but make it complicated. And in an era where there's a scrambling for funding, less likely to necessarily have the money move to where the residencies should be trained. In fact, we frequently found the last people who really understood where the money was were the program directors of the graduate medical education programs.
You know, I would just weigh in. I'd be remiss I do think that the teaching hospitals continue to believe that they are very, very important venues of training for the nation's physician workforce. It's the place where there is large aggregation of human illness, human disease, and human injury. So when you're teaching people to differentiate between illness, injury, and wellness, and what symptoms mean and what symptoms don't mean, the teaching hospital setting is still a very, very vital part of the educational experience, which isn't to diminish your point that there are other appropriate settings of care where training can take place. But I think but the reason that the financing of GME has resided in teaching hospitals for so long is they have been they still are the place people go to receive medical. You know, it's really interesting. Hospitals there are a lot of hospitals, teaching hospitals in particular, that are very full today. They're very full up with people who are very sick. And so this idea that hospitals will become of diminished importance, the ones that do survive on this mountain will still continue to be extremely busy in providing a valuable service to our community and our society.
I do think it's really important for us to understand how we can leverage the benefits of the teaching hospitals with new models of delivery of education in the ambulatory area. The CHAMPS program that's been published and suggested as another mechanism. Certainly the teaching health centers are a fundamentally new adaptation that will give us a new set of tools to provide training not only in family medicine but in internal medicine and pediatrics. I think it's the blending of those two more effectively and more efficiently that will give us a new model.
Okay, with that, we need to take a short break, and we will resume in about 5-7 minutes. Stay on time. Thank you, panel. Well done. Well, we have a distinguished panel of 4 speakers, and I'd like to begin with David Sklar, a physician and distinguished professor emeritus at the University of New Mexico and editor-in-chief of the journal Academic Medicine. With that, we'll turn it over to David.
All right. Yeah, thanks, John. Let's see. Okay. Well, I have to say, having heard this recent story about climbing the mountain, particularly Kilimanjaro, I have to relate a very brief story of my own about Kilimanjaro. I actually climbed Kilimanjaro with a group of people, and at about 15,000 feet, one of the people developed high-altitude pulmonary edema, and so I helped carry that person off the mountain. Fortunately, he survived. But I am a strong advocate of oxygen, so I'll just start with that. In any case, so my talk I titled Response to the IOM Report, The Good, the Bad, and the Ugly, and some of you may remember that movie, and there are a lot of people who get shot and a lot of blood, and it's hard to tell who is good, who's bad, and who's ugly, but in any case, it helped me to organize my remarks. And I thought that first, I would start, since not everybody here is a GME expert, to talk a little bit about how the workforce flows through the system. And many of our discussions today are really focused on the first part of it, what I call phase 1, which is as our students, pre-med medical students, and graduate medical education, our residents and our fellows come through the system. That's really only the first phase of this whole workflow through the system. The next phase is what we would call delivery dynamics, and that's really dependent upon a few things. One of them is the efficiency of the system, but another is the demand. And I think we haven't really spoken very much about the fact that there's going to be a huge increase in demand over the coming years as we have an aging population that accumulates more and more chronic diseases. And the way that we deliver care, particularly to a group of people who have chronic illness and multiple chronic diseases, is going to be very different from, I think, the way that we have often focused our educational systems. And it is going to require teams, and it is going to require an understanding of the small percentage of patients who end up being responsible for a large amount of our costs. So if we want to actually look at the triple aim and reducing spending, that's going to be very important. And then the last phase, which we hardly talk about at all, is the attrition phase, where we're actually losing our workforce to retirement or part-time, things like that. And I hope as we have our discussion, we talk about all of these phases because they all go into a recognition of what we're going to need in the future in terms of meeting the needs of our country. And I've illustrated them also in this way on a different schematic. Just to remind us of the fact that it's not just the physicians, it's also the nurse practitioners, physician assistants are an important part of it. They don't do a residency. So just, even though we're talking about graduate medical education, I want people to keep in mind that right now the nurse practitioners and physician assistants are not doing a residency. What are the implications of that? Right now they get their training by working with practicing physicians. We haven't really spoken about what the impact of that will be, particularly if we increase the numbers there. What will that be? What will the impact of that be on our workforce and our efficiency? And then the circles are sort of to illustrate the gap between our workforce and the demands of the population, which we don't always think about in terms of those demands going up and up, and some of the inefficiencies in our system that we currently need to deal with. And then, of course, the attrition part, which again, could be a whole discussion. So now to the report. I have three reactions mostly that I'm going to talk about, and I'm, again, defining them as good, bad, and ugly. And good, clearly the transparency recommendation is good and needed. And in fact, many of the discussions that I participated in with some of the members of Congress's staff folks were all about transparency, people recognizing that their states were not getting what they thought was an appropriate amount of the funding, and particularly some of the rural states didn't understand where that money was going. They went into a kind of a deep black hole. I think that recommendation is absolutely needed, and I think when this IOM committee was put together, that was one of the really strong messages of what was hoped to come out of some of these deliberations. Next is what I label bad, and the reason I call it bad is it has to do with the assumption of workforce adequacy that I think is implied in the report. And the reason I think that's bad is because some of the previous data that we've used to try to help us plan graduate medical education has suggested that there was going to be as many as 100,000 fewer physicians than what we needed. That was based on a model that Ed Salsberg and Michael Dill were responsible for, and HRSA came along with somewhat similar findings right around the same time. And I think it led to some of the AAMC's recommendations to increase class size. Now, the report throws into doubt some of those projections, but it does so without providing an alternative model. And I think that's a problem. I think it's a problem to just say we're not really sure, we're uncertain, without providing some guidance as to, well, what do you think? It sort of reminds me of if someone was concerned and came to me with a concern about cancer, and I said, well, I don't know. I don't think that would be a good enough answer. I think they'd want to know, okay, well, then what? How are you going to find the answer? And I'm going to talk about what I think would improve that conclusion in the report. I think a way to maybe look at that in a slightly better way. And then ugly, what I mean by ugly is that these aren't really what I would say bad recommendations or bad conclusions, but I think that they aren't as good as they maybe could be. One of them has to do with the two funding streams. And the reason I call it one ugly is because, as recommended in the report, it's based upon the amount of money being the same as what it is right now. And I think the problem for that for program directors is going to be if I have a program and I don't know whether I'm going to lose 10%, 20%, 30%, whatever of my funding for my residents, I'm probably going to be afraid to make a commitment to the full complement of residents because I don't know if I'm going to get that back. And I'm not sure that'll happen everywhere, but I think that certainly some programs that may be the effect. And so I think there may have been another option here to accomplish what I think is a very good goal, which is encouraging innovation in GME, but perhaps with a slightly different twist on how that might have been accomplished. I think the new federal committees and a center in CMS are reasonable. I'm not sure the politics, and I know others will probably be here to talk more about the politics, but whether the politics will sustain that, since we certainly haven't gotten any funding for the Workforce Commission, is this something that's going to be politically feasible? I have my doubts, but in any case, I do wonder about that. And so my question to that would be, well, if we didn't get that, if we can't get the funding, what could we do? How could we organize a better oversight system without any legislative finding on that or recommendation for it? And finally, Medicaid, where I think actually the reason I call that one ugly isn't because I think that the recommendation is wrong, but I think there's actually more opportunity there than maybe the report actually provided. I see a lot of promise at the state level, and I see a lot of states doing things that are really very creative and some real opportunities through the transformation of Medicaid funds. So I think that may be a potential opportunity for us. So now how to improve the report, just in following up with some of my thoughts. I think for the two funds, it would have been if the operational fund amount of fund, programs would understand that they still had to provide high quality education, but that there was new money available to do innovation, and even small amounts I think would probably have had a huge effect. So I think that's maybe something to think about in terms of improvements of some of the recommendation. The other is I think that we probably really need to look at annual projections of workforce that I think we could do that would maybe have confidence intervals and help us understand what today is going to be the workforce 10 years from now, and do that every year, just the way that with projections of the Medicare fund and the Social Security fund. Annual projections occur, and they differ from the year before, and I think everybody understands new things happen. There are new trends. There's no reason why we couldn't do annual projections for work parties working together. So finally, just to answer the question of are we really meeting the needs through our current GME system, I think one of the things about the report that I was a little bit disappointed in is it didn't really acknowledge all of the great work that is currently being done in graduate medical education. People from all over the world come to our GME system because we have an outstanding system that produces physicians who are highly qualified and dedicated, and we have a very dedicated group of teachers for them. I guess I wish that there had been a little bit more recognition of all of the good things that are going on in our GME system, as opposed to concentrating on some of the things that aren't working quite as well. And I think probably to just take the metaphor of the oxygen a little bit further, I do worry that with some of the recommendations that we could actually cause some harm in a system that basically at this point is doing a lot of really positive things, providing really high quality physicians. Doesn't mean that we can't make it better, but I think we do need to be cautious and be careful about some of these recommendations that potentially could destabilize the funding of our system. So I'll stop there. Thank you.
Thank you, David. Our next panelist is Stephen Shannon, who is the president of the American Association of Colleges of Osteopathic Medicine. a post he's held for the last 8 years. He has a long history of leadership in public health, and I won't take any more of his time.
Yeah, please
Go ahead,
don't.
Steve.
For those of you who don't understand what osteopathic medicine is, there are 30 colleges of osteopathic medicine in the U.S., and our association represents those colleges and their graduates in graduate medical education. We've got over 24,000 students, which is 1 in 4 entering U.S. medical student in the U.S. is going to a DO school. So to answer this question up front and then to talk a little bit about it, are we meeting society's needs? To some extent, but we wouldn't be here talking about it if we were meeting them the way we should be. I'm going to focus for a few minutes on what I think those needs are, and quite frankly, most of those comments are related, are addressed in the report, and what is required to meet those needs, and then respond to some of the IOM recommendations on the mechanisms to achieve the changes, and then offer a few additional thoughts. The GME system should be training, I guess I should be moving along here. The GME system should be training a physician workforce that meets the current and future needs of patients in a healthcare system that's transforming and best able to provide focused, population-based, and preventive-oriented care. Such a system should prioritize supporting the creation of a stable, robust, and well-functioning primary care system, working to produce practice-ready physicians who are proficient in patient care and care coordination, are culturally competent, able to lead and work in teams, anxious to participate in the improvement of quality, manage complexity of chronic diseases, and understand the importance of managing costs. The primary care GME training should be supported in a variety of scenarios in which the primary care itself is delivered. Of course, hospital-based training in primary care for primary care deliverers is needed, but also training should take place out of hospital in communities, including rural and underserved areas where most care is delivered, and these are acknowledged in the report. And at the same time, we need the U.S. GME system should support non-primary care specialty workforce needs for the production of the surgeons and the psychiatrists and the oncologists and other specialists and subspecialists required. And that training should also occur in the context that will provide access to the services by underserved populations. All these issues and more are contained in the recommendations, and the report is also noteworthy because it supports sustained funding at the current levels, which, given the conversation about decreases by so many others, that's a plus. It recognizes the need for research, policy, and implementation infrastructure for GME, and establishes it or proposes to establish it as a high level at the Secretary of HHS level. It recognizes the need not to destabilize the current system, at least it talks about that, and tries to address that through gradual revisions of the existing legacy system of financing. It recognizes the need for providing mechanisms to support community-based primary care training out of hospital, builds a case around accountability, and recognizes that innovation is needed and should be supported. And it does not tackle accreditation of graduate medical education. And it recognizes that significant progress is being made along those lines, as was addressed a little bit earlier by Tom Nasca, and also has been addressed by the American Osteopathic Association's programs. For instance, the Osteopathic Postgraduate Training Institutes, which are consortium models that enable community-based education outside of the hospital system. And of course, all of these issues around GME, the Milestones Project, the Next Accreditation System, and the implementation of the single accreditation system by ACGME, AOA, and the AACOM are all positives and mentioned in the report, and I think and focusing on the financing is key to where we need to be, what we need to be thinking about. But there is some concern. Here we go. About the transition to the proposed framework, if it was enacted as described. there would be a per capita net loss of funding for graduate medical education, and that occurs in two ways, at least. One is it proposes to take the teaching health center programs, which are innovative programs that I think are beginning to demonstrate real solid findings, and move them into the Medicare funding system without any additional money, and also does the same with the children's graduate medical education, hospital graduate medical education program. And the other mechanism that might reduce payment is the actual funding formula, the per resident amount, which could result with decreases in funding to institutions that are providing GME. And so you have to ask what they will do with that when they face that decrease. Will there be lost positions and or programs? And if there are, which ones? Well, those not be the exact ones that are being proposed as most needed. There's concerns about centralized management becoming politicized, and how could that occur? How could that implementation occur and prevent that? And then the Medicare system itself, is it too unstable to accommodate this level of management of GME? Though the recommendation to maintain GME in Medicare is good from the purposes of stability of funding, it places a lot of reliance on the ability of CMS to transform its focus and the way it does business, and it's hard to imagine how to bring about that kind of transformation in an entrenched and bureaucratically challenged agency. That being said, the proposal that comes out of the IOM here is groundbreaking and resets the stage for dialogue, and I think raises a number of interesting ideas on how to move forward. And from talking to the members, it's a proposal that deserves debate and measuring against political realities, et cetera. It changes the framework. I wish that there had been the ability to have the conversation wrapped around the financing and process of all of medical education, which is that 7 to 14-year period after getting into medical school that includes physician training and includes financing that's in multiple places. You've got the student financing through tuition and high debt levels related to that, the other kinds of financing that occurs in medical schools. You've got the GME financing, and you've got the patient care delivery funding. You've got multiple sources there, and it's too bad, and I understand the complexity of just doing what they did, but it's too bad they couldn't have looked at that whole issue and think about the whole process of medical education and the financial model and think about different ways that the whole piece might have been put together. I would add also that the report does recognize that GME funding is a public good, at least for the next 10 years. But it recognizes a social contract, if you will, that physicians should have. And I would maintain, and it does address this to some extent, that physicians trained to provide care with the support of Medicare and Medicaid funding should be expected to provide care to patients whose care is funded by Medicare and Medicaid. And final comment, this report does not address many things that have to be addressed in some kind of interim period, like the funding of teaching health center programs, which is limited, was one-time funding through the ACA, and unless there's some kind of action on that in relatively near future legislatively, the funding will run out on those programs. Even before they're able to demonstrate the effectiveness, you can imagine the instability created by a lack of surety of funding. So while this sets the framework for the dialogue, there's a lot of things that have to be done in the interim, and I look forward to the dialogue here as well as working on these issues in the future. Thanks.
Thank you. Our next speaker is Ed Salsberg, who is a national leader in health workforce research policies and data for the last 25 years or so. He's currently on the faculty of George Washington University. Prior to that, he was the founding director of the National Center for Healthcare Workforce Analysis in the Department of Health and Human Services, and before that, he directed a center, he created a center at the AAMC on the Center for Workforce Studies at the Association of American Medical Colleges. Ed.
Thank you, John. It's a pleasure to be here. I'm going to talk from the workforce planning perspective in terms of workforce data. Clearly, some of the concerns that have been expressed about the report since it was published have been about whether this would, in fact, make worse the potential shortage of physicians. So I really want to focus on what I see as the likely outcomes and why I like this report in terms of workforce planning. First, why I like this is in terms of the workforce. These are some of the angles or the aspects of the report that have already been mentioned. It does hold GME constant, and it does inflate it or increase it for inflation. If you think that you're likely to be getting more money from Congress for GME, you would call holding funding constant a loss. If you think that Congress might cut your funding, you might call holding GME funding a positive. I view it as a positive given the concerns about the budget from Congress. It does increase funding for training. It basically takes the money from IME, which is indirectly supporting training, and puts it into the training programs. It flows funds to the GME sponsor, who we should be holding accountable for the quality of the medical education, of the graduate medical education, and the outcomes. It detaches it from Medicare inpatient days, which I think is important if you think that we're trying to keep patients out of the hospital and relying on a sort of a dwindling share of use of inpatient days I think makes it unsustainable in the long term. I like the per capita but per resident amount because of the inequalities across the country currently. It supports the expansion of GME, and it provides a solid funding for teaching health centers and Children's Hospital. I agree with Steve Shannon's comments that we have a transition problem since it will certainly be several years before anything gets passed on this, and we do need to be concerned about support for the teaching health centers. And it supports innovations in GME very, very explicitly. I think there are two key workforce questions I want to focus on very briefly. First is, are we facing a general physician shortage? And the second is, would the IOM GME report make that shortage worse? The question, are we facing a shortage? I have a sort of unique position, having been responsible for the AAMC projections and then the HRSA projections a few years ago. So I've been looking at this for many years. And the AAMC projections were about a 45,000 primary care physician shortage in 2020, and then about a 90,000 in 2025. The more recent HRSA reports, which many of you may not have been as aware of, it was released at 2 p.m. on Wednesday before Thanksgiving, so that may account for some of the reason it didn't get the attention that it might have gotten, came to the conclusion that the shortage would be about 6,400 primary care practitioners in 2020. The difference between the HRSA and the AAMC findings really relates to using more updated information and some slight changes in the methodology, but basically the same methodology. The reality is that the world changed from when we did the initial AAMC projections and when we did the HRSA projections and where we are today. And the passage of the ACA and really the recognition of the unsustainability of cost increases and the change in the delivery system are really among the factors. I'll come back to that in a moment. I think when you look at the data closely, and some of the new data coming out really supports it, is we are facing serious maldistribution problems both in terms of specialty and geography. But it's not a general shortage for the nation as a whole. And I think if the problem is a maldistribution one, it calls for different solutions than if it's a general shortage of practitioners. So I don't think, and I know this is, contrary to the current wisdom and the common mythology, that we are facing a national shortage, a national general physician shortage in 2020 and 2025. The healthcare delivery system is changing. We have an enormous surge in the number of NPs, PAs, and other practitioners. The incentives for delivery are changing, and there is now, I think, a greater opportunity to make use of these non-physician clinicians and other health professionals. There have been problems and issues with the implementation of the electronic health record, but I really believe that the e-health and telehealth hold tremendous potential going forward. And I want to recognize the flexibility of the healthcare system. Providers, individual providers, group practices, hospitals are obviously facing problems. But if you look at what happened in Massachusetts, I think it's an example where providers, in fact, can meet the demand. If they see the patients at the door, we have an incredibly creative and entrepreneurial healthcare delivery system, and providers will try and meet the needs. So I think that we have the tools in place, and I think we're moving forward. Then the second question is, will the IOM committee reports lead to a worsening of the shortage or what might be a shortage? And I want to be clear that the IOM committee report does not say that they would not support GME funding. In fact, they recommend ending the blanket cap on GME positions that Medicare now has and would support expansion. In fact, it puts recommends $1 to $3 billion over the decade per year for expansion and innovation. It doesn't say how much is innovation, how much is expansion, but that's a real pool of funding for new GME programs. The GME they're calling for is not across the board, and it's not that anyone who proposes a new GME program would be funded. It would be people who can demonstrate and document a need for a specialty in their region or in the nation. And so I recognize that there are still technical challenges of knowing what specialties are needed where. But I think we are also making progress. I think some of you may have seen the work that was done that's come out of the Sheff Center at UNC, where they've really, I think, advanced the modeling to better understand what our workforce needs are at the local level. So I think in general that the IOM committee recommendations would support an expansion of GME that is targeted to our needs, and that is actually really consistent with what our needs are. It's not a general need for physicians. It's a need for physicians in selected specialties and selected communities. Oops. Can I get back, John? There you go. Let me close by saying that I think my opening premise is that the current system really does need to be changed, that it is outdated, it is inequitable in terms of the programs across the nation. It has unintended consequences and I think discourages and makes certainly very difficult the training of physicians in ambulatory settings and where you want to train them because the funding stream is so closely tied to inpatient use. And I don't think it's very close. It doesn't direct us in terms of the types of physicians we're going to need in the future. I want to be clear that I think the IOM committee recommendations are a framework and not a blueprint. They provide a framing for how we might approach GME financing in the future. They are not saying, they have not filled in every detail. And I think it was, as was already heard today with Gail Wilensky, that there are some areas where clearly the committee debated and there is an openness to how they might actually be implemented. And I think some of the issues that have been raised by the other speakers are legitimate and have to be addressed as we go from the framework to actual legislation. I think we do really need those targeted investments in GME in America, and I think this offers us a vehicle to get there. I want to be clear because I guess I'm responding to some of the criticisms of some of the interest groups that this set of recommendations would not destroy GME as we know it. It does not change the basic approach to GME. It is a challenge for academic medical centers and teaching hospitals because of what they would do in terms of the indirect medical education. It would provide more support for the education side. We need to also pay attention to the issues that have been raised around the future of academic medical centers. So I think this is a time for a constructive dialogue, not the narrow protectionism. So the issues that are being raised today are important, and we have to keep them in mind. But I really urge all of the interest groups to come to the table and begin the dialogue for how we might make this set of recommendations a reality. Thank you very much.
We'll move right on to our fourth panelist, Debra Weinstein, who was a member of the IOM committee. She's also the Vice President for Graduate Medical Education at the Partners Healthcare System in Boston. And she's been a leader in GME for many years, and I won't take any more of your time, Deb.
Thank you so much. I think I'm going to start just by trying to complement Gail's excellent description of the committee recommendations with another way of characterizing them, because perhaps the most important part of the report is the least explicit part of the report. And that's because we really saw this evolution as having two phases. And the first phase, which is probably going to take at least 5 years to fully implement, addresses inequity and inflexibility of the current methodology for distributing funds. The more profound change is the second phase, and that is where the committee tried to describe an outcome-based distribution of GME funds, which really mirrors what's happening in healthcare more broadly. That's the very ambitious part that's going to require us to figure out and get consensus over a broad range of groups. What are the outcomes that are important, and what performance metrics can we use to measure those outcomes? So we need the phase one, and we need, very importantly, the transformation fund and all the activities that would go with that to get to the point where we can have an outcomes-based, performance-based GME funding system. I think the governance structure that's been described also is an important element for getting to that phase two. So I'm going to very quickly touch on a couple of points from the slides, but try and leave time for discussion. In terms of whether the pipeline is sufficient, GME can't alone really address all of these issues. Diversity is obviously a very important goal that isn't in the realm of GME because we deal with the graduates from the medical schools, and that has to be addressed prior to medical school and probably even prior to the college age. How many is something that GME can respond to, and as Ed suggested, the report allows for more positions within the same funding envelope, and that's an important consideration, but it uncaps the number of funded positions. Where do graduates practice? This is an important tension point because GME is not the answer by itself to populating underserved areas. It is one influence. Other influences include where people grew up, where physicians go to medical school, and certainly quality of living and compensation issues in terms of the practice during their later career. Specialty and subspecialty distribution is very heavily in the realm of GME, and that's something that the report focuses on. Again, not in terms of specifics, but in terms of setting up a system that will allow us to tune incentives later on to make sure that we can respond to changing needs in this area. And then preparation for practice, which was, of course, the focus of the second Macy report that in part stimulated this whole effort, is squarely in the realm of GME and something that we need to spend a lot of time on. So I'm going to actually skip to this last slide looking at the transformation fund and the opportunities embedded in this. Exploring new payment models. How can we use government funding to ensure that we are meeting the needs of the population? Can we incent by different per resident amounts for different specialties, for different practice regions, so that we know that the pipeline is tuned, and do that in a way that every 5 or 10 years, based on data analysis from every year, we can change the policies and the processes. And that was part of what was behind this idea of a GME council. New educational approaches. We have not rethought the fundamental approach to graduate medical education or physician education overall in a very long time. And the kind of efforts that could and should come from this transformation fund, not only because it allows funding to scale, but it provides the coordination for the kind of research that we need to do, would allow us to examine what's the right mix of experiential learning to other kinds of simulation, other kinds of learning. What's the right duration for physician training? What's the right categorization of specialties? We keep adding more and more and more subspecialties. Should we take a step back and rethink that? And then again, additional slots is allowed for through the Transformation Fund. So clearly there are risks involved. A number of them have been articulated, and there are probably other unintended consequences that we need to worry about. But I don't think we can get paralyzed by those worries, because the risks of doing nothing are pretty significant as well. We shouldn't settle for processes and policies that are decades old, and we need to change as the healthcare context changes. So even if we don't have agreement on all or perhaps any of the recommendations, we need to seize this momentum to see what we can carry forward. And if certain recommendations aren't perhaps the best way forward, then we need to improve on them and think about how we can achieve real change and develop a system that is flexible and equitable to move forward. I'll stop there. Thank you.
Thank you. We'll take a few minutes for questions of our four panelists. If you'd identify yourself, wait till you get a microphone. We'll begin here and then go over here.
Hi, I'm Julie Cantor-Weinberg with the College of American Pathologists. I wanted to thank you for that great presentation, and I think we all agree there really is a problem with primary care physicians. I worry, though, as representing hospital-based physicians, that the report has this great idea of moving training out of the hospital, and there isn't a recognition, if you're talking about physicians like pathologists, that
Do you have a question, please?
I just wondered how the folks address how the move should go for folks that are primarily hospital-based.
Okay.
I can address that.
Go ahead.
There isn't a specific goal to move training out of the hospital, but to allow training to occur in whatever settings are appropriate, and obviously that will vary by specialty. So the funding needs to be flexible enough to follow the educational purpose.
Okay. There's a hand there.
Hi, I'm Tom Hunley from Minnesota. I'm a chair of the Health and Human Services Finance Committee in the Minnesota Legislature and chair of a legislative commission on healthcare workforce and a retired medical school professor. Could somebody explain the difference between the geographic adjustment of payment versus the geographic distribution of physicians?
Deb?
Okay, I'll try that. So I think it's possible to interpret a quick read of this very complicated report as setting out a goal of redistributing the GME positions according to population. And that was not a specific goal. I think the real outcome everybody's interested in is adequate access to care. And that's related to where physicians practice, not necessarily to, or not directly to where physicians train. So again, the issue is flexibility. The current system locks, to a large extent, training into sites where, or geography where training has traditionally occurred. And the proposed recommendations allow for movement of slots, again, eventually based on a performance-based system, to new sites. Does that answer your question? Okay.
Yes, ma'am. Mm-hmm.
Hi, my name is Andrea Lowe. I'm from the American College of Preventive Medicine. My question is regarding examining and developing targeted investments based on specialty maldistribution. Our specialty is one of the smallest medical specialties, and the residency programs tend to, while they're eligible for Medicare GME, they generally don't receive a lot of it because they are mostly community-based and outside of that hospital setting. So would that research and the targeted investments would include specialties such as ours that could be funded by GME but mostly include non-hospital settings?
I think it would. Sorry, were you talking about preventive medicine? Was it? Yeah. Yeah. Gail may remember better than I do, or Jill Eden, who's in the audience, whether there was specific mention of preventive medicine. But I think the spirit is that no specialty would be excluded.
Ed, I have got a question for you. What seemed to be your change of heart in terms of whether there is a shortage, will be a shortage, is based on new data. Do I have that right?
Yes. Mm-hmm. New data, and I think the growing awareness of the impact, the potential impact of the changing delivery system. When we were working on the earlier AAMC numbers in 2008 and 2010, while we had been talking as a society about the need to change delivery, there was not as much activity underway, certainly as there is now. And and maybe perhaps having been at HHS and seeing the work that some of the innovations and changes that the ACA seems to have helped spur on, it certainly feels that there is a lot more going on now to look at, to use workers differently. And some of those are very encouraging. There's a long way to go. And the other part, I think, has to do with the enormous growth in the non-physician clinicians in some work, which says that they are accepted by the public and as part of teams, which are also being more promoted more aggressively, that we can deliver services effectively and make better use of our physician workforce.
Mm-hmm. David, you get the last word here.
Okay, thanks. Yeah, I think it's great to say that there's new data, but I think that needs to be shared with everybody so that we can all look at it, because certainly there are other things that have been changing. For example, residents now are subspecializing, and for a lot of reasons. I mean, the level of knowledge that they're trying to master is much greater. What's the impact of that going to be on the workforce? We don't know. A lot of physicians who had delayed retirement, now their retirement accounts have improved. They're going to retire. What is that going to do? So I think the point is that if there is new data, we need to all be able to look at it and analyze it and then come to a conclusion about what the impact is. I don't think it's enough to say, well, there's new data, so we're all okay.
Well, I don't think the data is secret, is it, Ed? I mean,
No, it's not. It's definitely not secret. But I think David Sklar is right that we have not had as much of a public discussion, and most of the observers seem to cite old studies, and it is a good time. The work that, as I mentioned, that the Shep Center UNC recently published on their new tool, I think will lead to the publication of more robust workforce analyses.
Okay, thank you. We've got to cut it off. Sorry, because we're running a little bit late. So please join me in thanking the panel, and we'll move on. All right, we're going to move on. If you want to talk, please go outside. Our first panelist is Atul Grover, who's well known to everybody. That's right. He's at the AAMC, and he's very important.
Oh, man. I love John. So I want to, we've talked a lot about an economic perspective and policy perspective. I want to bring it back for a second to the patient perspective. And my mom turned 75 next week, and luckily she's doing well. And she has managed to live through bouts of cancer and diabetes and joint replacements and all kinds of things. And the reality is she hits this column very soon. So this is the per capita use of physicians by age cohort in the country. And so I see my mom, and I talk to a lot of her doctors, most of whom she actually needs to see when she sees them. And I know we talk a lot about unintended overuse, but as patients get older, they use more services. And it's primary care, it's medical specialties, it's surgical specialties, and it's also other specialties like pathology. I'm, in fact, for another family member trying to arrange a pathology second opinion at the moment. And here's the truth of what's going to happen. So I think it's great to talk about, well, I feel that there's a lot going on in the healthcare system, that I think there may be a lot of changes in delivery, that there's a lot of great promise. And I remember this just like Mr. Lipstein said back in the 80s, we just called it an HMO rather than an ACO. And we said this is going to change the world, no one will ever get sick, but you can't really deny older people use more care, and there's a lot of older people coming. We talked about the doctors we trained today being around in 2050. That's good, because I'm not sure the baby boomers are ever going to agree to die. I also want to talk about those unique patient care services that have been mentioned. And I think, the IOM report raises a lot of good points, and I think it really stresses the need for a continued investment in graduate medical education and the training of our future healthcare workforce. But there's also a great need to provide care to patients who are vulnerable because they're medically vulnerable or they're socially vulnerable. And Congress, back in the 80s when creating this adjustment, and Bruce can certainly educate you on this as well, said the IME, about $6 billion a year Medicare payment, is for patient care services, the unique services provided by the institutions that provide level 1 trauma centers, burn centers, loss leader services like inpatient mental health services. Where do you send your patients when they come back with Ebola? I have to support that infrastructure whether or not I need it. I pray I never need it. I pray my kids never need it, but I want it there 24/7, 365 days a year. And it's also because we can't measure the complexity and the severity that well of these patients, even though we've improved the DRG system over the last 20 or 30 years. The R-squared on that is still less than 0.5. So we have a long way to go before we can measure these things perfectly. And what I would say is, again, back to the patient care perspective, I think the IOM sort of said, well, let's forget about the $6 billion a year that we use to support those unique patient care services that are there when we need them or when our families need them or when our neighbors need them. What are we going to do about that? And if we built a system from the ground up, we would pay differently for education, but we would also pay for the full cost of running a trauma center or seeing a geriatric psychiatry patient. We're doing a lot of other things that our system just isn't generated to take care of right now. Access is also an issue. And I think even though Dr. Weinstein said location and distribution, geographic distribution, was not a major facet in this report, it was a major issue for the senators who requested the report. And so what I wanted to point out was that you can start new teaching hospitals. And in fact, if you look at the number of or percentage of hospitals in a state like Arizona that are teaching hospitals, it's 17%. They have chosen not to start new teaching hospitals. If you look in a state like or a city like Washington, D.C., it's over 80% teaching hospitals. And if you look at major teaching hospitals that have been willing to train an exceptional number of physicians and provide those really unique services I mentioned, you can see the striking differences, that there are only 2% of hospitals in Kansas, 3% in Texas, 4% in Colorado, versus a place like D.C., New York, or in Massachusetts. So we can create new training institutions if we want to, and we've actually put out a guide so that people can do this to encourage the expansion. But in fact, if training physicians was such an economic boondoggle, these numbers would all be 100%, and they're not. So the last thing I want to just mention before I pass it on to my colleagues is that yes, there's a lot of things that we can be doing differently. Telehealth is really a fantastic promise. We've been talking about it for 20 years. I was in western Wisconsin last week, and I couldn't even get cellular signal. And my father-in-law's satellite dish was down, so we couldn't get any internet access any other way. I literally had to drive the 20 miles to town to get on my BlackBerry. Telehealth holds great promise, but we got a lot of work to do. It's not going to happen tomorrow. And so you can feel like it's great promise, and you can feel like ACOs may change the world, but there is no evidence thus far that ACOs, which we are very participating in, our institutions are a plurality of pioneer ACOs, of CMI Innovation Grant awardees, and we're also a large convener for bundled payments. There's no evidence any of that has reduced workforce needs thus far. And so we want to use every member of the team, try to figure out how to better approach our efficiencies in care. We want to figure out how to use technology to make that care better. But what we've suggested is that you probably need to directionally train a few thousand more physicians a year. And we've also agreed that we should be held accountable for the funding that we receive from the public, because I don't want to go out there and not be able to make that argument to the public. That's just the way things are moving. We've endorsed legislation in the House, H.R. 1201, that would tie 1 to 3% of IME payments to those accountability metrics, the same things that MedPAC has recommended. Where we differ is we just don't think we can put 50% at risk year to year, because then, as I think another one of the panelists mentioned, I can't determine if I can support training from year after year or maintain that trauma center. We also believe that we should be more transparent because, again, I think if you add up all the costs that are really difficult to quantify, but the cost of all that standby care, the cost for making sure you can take care of an Ebola patient if they come out to University of Nebraska Medical Center or somewhere else, is vitally important. And I think those are the discussions that we need to continue to have moving forward, in addition to how do we train the next generation of physicians, because it does come back to patients like my mom, and I don't want to fail her because I'm thinking in theoreticals.
Thank you. Our next panelist is Glenn Hackbarth. I have to tell you, he's a hero of mine. He has been chairman of the Medicare Payment Advisory Commission going on 15 years now in this highly partisan environment in which we all live, and he gets along on both sides of the aisle. Glenn?
Thank you, John. Can I get a glass for some water? Under the best of circumstances, my voice is pretty scratchy, but I flew from Oregon to D.C. last night, and I left most of my voice over Iowa or someplace, so I hope you'll bear with me. That water will really help. I hope. Thank you. As John mentioned, I chair the Medicare Payment Advisory Commission. And in June 2010, in fact, we made our own recommendations on Medicare funding of graduate medical education. And I want to begin my comments with really the premise of our work, MedPAC's work, which is that those involved in graduate medical education have really done a superb job in pursuing the mission, the historic mission that we assigned to graduate medical education, of training thousands of skilled clinicians in the latest diagnostic and therapeutic techniques, advancing the frontiers of medicine, and in serving as linchpins of community healthcare systems. That record needs to be acknowledged. Our view, however, is that whatever that past success was, and however much it should be applauded, what society needs now is a little bit different than that. Not a 180-degree change of course, but a significant redirection. And the role that we think is needed now is to train clinicians who are prepared to serve in and lead a 21st century healthcare system that is both high quality, equitable to the entire population, and economically sustainable. And it was our judgment that continuing what's been done in the past, however wonderful that was in the past, will not produce the results that society needs in the future. And when any enterprise receives large-scale public subsidies, they need to respond to society's current needs, not past needs. Over the last 4 years since the MedPAC report, I've met with many groups involved in GME. In fact, I've met with more people in this subject area than any other that MedPAC is involved in, because I think this is so important to the future of American healthcare. And the fact of the matter is, as some of the prior speakers mentioned, is there are a lot of people involved in graduate medical education and involved in accreditation, both of graduate medical education programs and board specialty accreditations, who believe the system needs to change in order to produce the sort of physicians we need in the future. That's not an external view. There are a lot of people within the community that deeply hold that belief. But I've also heard many of those same people say there's a lot of inertia in this system. And we need an external catalyst to speed reform of the system. And it was our view that Medicare, as a significant funder of GME activity, could help be a constructive catalyst to get us to where we want to go. Now, I'm going to mention 4 areas of overlap between the MedPAC recommendations of 2010 and those in the IOM report. First, like IOM, MedPAC recommended that funding government subsidies for GME stay in Medicare and not be moved outside, as has often been discussed by others. We believe that was important both for stability of funding and it also may also be the best of the lot of the practical alternatives we have in terms of equity of funding. Some people have said there ought to be a surcharge on insurance premiums. I'm not an economist, but economists tell me that, ultimately the insurance companies wouldn't bear that tax. It would be passed on to policyholders as a head tax, a flat dollar amount regardless of income. The Medicare financing system based on payroll taxes isn't perfect, but it's a more equitable financing mechanism for a public good than a flat head tax. So keeping it in Medicare probably is the best of the practical alternatives available to us. We also MedPAC said that the goal shouldn't be to cut Medicare subsidies for graduate medical education, but rather to use them to catalyze improvements in performance. By the same token, however, we did not think that there should be an increase in subsidies without a better understanding of 2 issues. One, the workforce issues that have been discussed by a number of people before me. And a second issue, which I don't think has been touched on, is without a better understanding of the economics, if you will, of GME. There's been a lot of talk about the costs of running a GME program. There hasn't been any discussion of the revenues that are associated with running a GME program. It expands the clinical capacity of the sponsoring institution, which brings in revenues. How those revenues and costs net out is very poorly understood, so far as I've been able to tell. The IOM tried to look at that issue and found very little constructive information on the topic. The fact of the matter is that not all specialty programs may require the same level of government subsidy to exist. Some may be profitable on their own merits without any subsidy at all. Others may require government subsidy in order to exist. We shouldn't be increasing subsidies until we better understand both the number and specialty mix of physicians and the financing needs. We also agree with IOM that there needs to be more transparency and accountability. I won't dwell on that. That point's been discussed often. I would highlight, as one of the speakers did, and I apologize, I can't remember who it was, that IME funding is really medical education funding in name only. The money goes into the general funds of the teaching institutions, and it can be used for whatever purpose the board of directors and executives of that institution believe are appropriate in pursuit of their mission. That may be involve supporting medical education, graduate medical education. It may be involving mergers, buying other institutions, buying physician practices, advertising. The money just flows to the general fund without any accountability for how it's used. It is not graduate medical education funding. We also agree with IOM that we ought to cut the link between Medicare volume and the subsidies, and that the current calculation of per resident subsidy amounts based on historical costs is grossly inequitable and needs to be updated. And finally, we agreed that there ought to be a transition so as not to inappropriately disrupt this important enterprise. 3 quick concluding points. One, I want to be clear that we did not believe that the problems our country has with the maldistribution of physicians geographically or problems with specialty mix, those problems can't all be laid at the feet of the GME training programs. How Medicare pays for care and how private payers pay for care are as even more important, I would say far more important, reasons for that maldistribution of specialty and geographic distribution of physicians than anything that GME programs do. Second, it may well be, as Atul and some others have said, that there are very important functions carried out, care delivery functions carried out by teaching institutions that are worthy of public support. I believe that to be the case. But to run the money through this sort of subsidy system where it's not targeted to the institutions that in fact carry out those social responsibilities is not an appropriate use of taxpayer dollars, just as we think there should be more accountability in graduate medical education for how the money is used. If we're using dollars for other socially worthy purposes, there needs to be accountability. Some institutions, I dare say, are receiving a lot of IME dollars who are not really carrying their fair share of the load in terms of those social responsibilities. Last point. In Washington, infamous for its gridlock, the status quo always has an advantage. So those who like the current system have a political edge. The question, though, that they need to ask themselves is whether the base of that support is eroding away as a result of reports like IOM, MedPAC, the Macy Foundation, and others calling into question the current system. The alternative here is for the subsidies just to be cut. There will be a point, I don't know when it will come, where there will be an urge to find money to do something. And as the system currently stands, I think it is very vulnerable to being cut when that next wave comes. And so if I were in the graduate medical education community in supporting the need for improvement, I'd say let's use this opportunity to build a stronger, durable foundation of political support, not just ride the status quo. That's all I have to say.
Good. Thank you. Our next presenter is Bruce Vladeck, a former administrator of the Healthcare Financing Administration, now a senior advisor at Nasca, a global leader in healthcare consulting. Bruce has a long career in health policy, politics, finance, you name it, and he'll present. Bruce.
Thank you, John. Good morning, everyone. I'm really pleased to have the opportunity to be here today. I have been involved in issues around GME in a lot of roles over a lot of years, and there are a lot of things I could say about the report. But the reason I'm here today and the thing that has concerned me the most and what I really want to talk about in the few minutes is really one specific issue that was, and my reaction was perhaps exacerbated or triggered by the fact that the report was released, the IOM report was released the day after the annual report of the Medicare trustees on the status of the Medicare trust funds, which reported, as I think you all know, that they're in fact in substantially better shape than had been anticipated in the past, but that they're still not expected to be sufficient at current levels of revenue and expectations about expenditures to fully fund the benefits that have been guaranteed to folks who are now paying in to those trust funds. And I was, in that regard, the way in which the report treats the $10 billion a year in trust fund money as sort of a pot to be raided for a whole variety of purposes, however valid they may be, was a particular concern to me, a concern that was exacerbated when I read the report itself, and to talk about how the committee chose Medicare funding in order to finance this reform of GME because it was an entitlement and therefore a more stable source of funding than appropriated funds for, say, pediatric GME. And I understand how the word entitlement is used in Washington budget terminology, and I understand the difficulty in funding anything through appropriated accounts in the current environment. But in my experience, Medicare is an entitlement to the beneficiaries. That's why it exists. It creates an entitlement to a specified set of health care services, not an entitlement to policymakers or to particular institutions that are receiving the money or anything of that sort. And if, as a matter of pressing public policy, it is important that we fund innovation in graduate medical education, and I absolutely agree that it is, we have to not get caught in the trap of contemporary Washington discourse in which the only acceptable way to even discuss talking about funding something important is by taking money out of something else that may already also be important. And that's what I'd like to talk about just a little bit further with just sort of a few facts. Medicare is approaching its 50th anniversary of the signing next year of implementation the following year, and throughout its history, Medicare payment policy has been guided by one basic principle, which is in the statute and has governed policy at first the Bureau of Health Insurance and then HCFA and now the Centers for Medicare and Medicaid Society. Medicare's obligation and responsibility is to pay the fair share of the costs of clinical services provided to its beneficiaries. And that's the rubric, that's the rationale, as I will elaborate a little bit further in a couple of minutes, for the support of GME expenses in the Medicare program. The other problem, and what causes so much confusion in all these conversations, and is really, in my view, central to the conceptual muddle in which we find ourselves, is that the services provided by hospital house staff are, in economic or accounting terms, classic joint products. That is to say, clinical care, education, and training are provided simultaneously in the provision of the same activities, in the pursuit of the same activities, in the provision of the same services. Parenthetically, that's one of the reasons why the NLRB and the IRS have had such a hard time over the years figuring out whether residents are employees or trainees. They are both simultaneously at the same time. And so that any notion of how the value of or the costs associated with, say, a resident are split between education and clinical care is intrinsically arbitrary. And I think that's just not widely enough understood, and it's very important about this. But given the history of the evolution of Medicare payments to hospitals, which, as you know, was originally modeled on the prevailing practices in private health insurance, particularly Blue Cross plans, prior to the inception of Medicare, which was based on a set of standardized charts of accounts and rules for determining reasonable costs for hospitals. The salaries and associated benefits and expenses associated with house staff and all other employed physicians in hospitals were part of standard allowable hospital costs long before the Medicare program existed. And they were, in fact, kind of rolled into Medicare payment policy when the Blue Cross cost reporting rules were adopted as the basis of Medicare payment at its inception. Due to caps on on the per-resident payment, going back to the Balanced Budget Act, Medicare is, in fact, now paying somewhere around half, 60%, somewhere in that range of the actual costs hospitals are incurring in direct graduate medical education. To that effect, that proportion, a little shortfall, may well be a disincentive to hospitals, cap or no cap, to expand residency programs. I also would say that in terms of what those costs are and how they are allocated, in fact, there is a high level of accountability if you define it by reporting. The problem has been that since the caps are so far below actual costs, in most institutions in recent years, the need to sort of audit them or evaluate them any more seriously would be sort of totally a waste of time. I think it's very clear on the indirect medical education side that the policy and statutory intent associated with IME and at the inception of the prospective payment system was very clear. Moving from a cost-based system to DRGs was a very radical change in the basis of payment and accounting in American health care. And the DRGs circa 1983, to be direct about it, really weren't that good as reliable measures of relative costs across different kinds of hospital-based conditions. And one of the ways in which they weren't adequately good was that they didn't adequately compensate for variations of intensity of illness or of services required within a particular DRG, and there was a systematic correlation between the extent to which an institution employed interns and residents in a teaching program and the extent to which its costs within a DRG were higher than the national median for that. And that continues to be true. The exact empirical level at which that's true has changed over years as the DRGs have been refined. We may almost be at the point where those numbers can be substantially reduced. The irony, of course, in all of this is that I think the extent to which we are probably overpaying relative to the original intent of IME is almost entirely balanced out in the arithmetic by the extent to which we're underpaying on the costs of direct graduate medical education, which means as an estimate at the institution-specific level, combined IME and DGME payments at the moment may serve as the basis for some kind of integrated payment in the future. But you really have to think about why there is so much variation in those costs and find a way to preserve the appropriate parts of that. And here I really want to disagree with my friend Glenn in this regard. IME was never intended as a medical education payment. He is correct, but to the extent that it was recommended to reflect costs of care, whether in burn centers or other tertiary services or so on and so forth, in the construction of the PPS, it was like every other operating cost of a hospital, where the initial rates were set based on some estimates of the cost, and public policy has been consistent since 1983 for everything but the pass-through costs, that as a matter of public policy, we don't care the extent to which your actual costs as a hospital for a particular case are similar to the costs that you incurred in 1982 in treating those kinds of cases. The point of prospective payment on a DRG-based system is to let hospitals reallocate how they combine resources internally to provide a set of services to patients. That's what prospective payment is all about. So to say that IME is there's no accountability for it because we can't, the money's not spent on medical education, is like saying there's no accountability for the component of the standardized DRG rate that's associated with laboratory services, because there's no necessary connection between the payment to a particular hospital for lab and the amount of lab services actually consumed. It's the same logic there relative to the PPS program. Finally, people might say, well, you know, we have this money at GME. We really have to change GME. We We don't have any other alternatives in Washington in 2014. We need $2 or $3 billion a year to fund innovation in GME, which is a proposition with which I don't disagree. And therefore, we can break the 50-year precedent and take some money that has been originally designed to pay for clinical services for Medicare beneficiaries and take it out of that pot and put it in a pot to pay for educational services for professionals who may never see a Medicare beneficiary either in their training or in the lifetime of their clinical practice. And it's a small amount of money and it's a separate pot, and so it's really okay. And I want to suggest that this really is, and I can tell you cite the first two of these instances from experience, that this really is a very slippery slope and one that I would be extremely nervous about entering into at all. Maybe to turn Steve's metaphor on its head, but coming down that mountain is the dangerous part, not ascending the slope. I think you can make a very powerful public policy case that if Medicare benefits were available to otherwise uninsured 64-year-olds with serious chronic conditions, the Medicare trust funds would save money over a period of time. I think you can make an even stronger case that with the growing prevalence of malnutrition among Medicare beneficiaries throughout the United States, Medicare should pay for food because their health status will be better and they'll be re-hospitalized less often. I recently got in a somewhat similar debate in New York about whether supportive housing for people with serious and persistent mental illness who are very frequent flyers in hospital emergency rooms should be paid for out of Medicaid funds. We definitely ought to pay for the supportive services program. Once you say you can pay for housing and food out of a health insurance program, there is no limit. And just to reflect the kind of mood I was in after reading the report, I think some would make the argument, not me, that you can improve Medicare policy by training more PhDs in health economics, and therefore Medicare ought to subsidize their educational activities. And I don't know the logical distinction between that and taking $3 billion a year out of GME payments. That was basically what I was going to say today, but I can't resist one other observation, which is the extent to which, and again, I'm reading the report more carefully, the extent to which this issue of geographical equity has come up again and again and again in the reasons for starting the report and the writing of the report and so on and so forth. And Atul touched on some of this very well. I've been dealing with this issue in one form or another as it affects Medicare policy for more than 30 years at the moment, and I will admit to some biases given where I come from and what parts of the country I think are important. But I would just point out as a matter of miscellaneous information that the United States Navy spends something like $8 billion a year building warships, none of it in New York State. And we used to have in Brooklyn the largest government shipyard in the United States. It is inherent in the nature of a federal system in a large and diverse country, and it is in keeping with good economics that certain economic activities occur in certain places and others don't. We don't get any wheat subsidies in New York City either. And so this red herring that there is some inequity, because before Colorado and New Mexico and Arizona were states, private citizens and local governments in New York and Massachusetts were investing in building academic medical institutions, and it's now unfair that a disproportionate amount of GME money goes to those things is just inconsistent with the way the federal government actually works.
Well, our wind-up presenter is Chris Daw, who's president of Daw Health Strategy, a private healthcare consulting firm. But before that, he served in the Obama White House on the National Economic Council staff. He's been at HHS as a health policy executive, and he's going to give us some thoughts, particularly around the politics of this broad subject and perhaps the way forward. Chris?
Thanks, John. And Congratulations and a thank you to the committee for creating what I think we would all agree is obviously a substantive and significant contribution to this debate, and a debate that I think, as Glenn rightfully points out, is as important as any that we are having in an ever-changing healthcare environment. And so, just my personal appreciation, and I think many share that. But as the report rightfully and appropriately points out, moving forward on the types of recommendations made would pretty much exclusively require moving through what we've heard come up time and again this morning, a notoriously challenging political environment through legislation. So with apologies in advance, I'm fortunately going to take what has been a wonderfully substantive conversation this morning and devolve it slightly into the darker arts of political tactics and maneuvering, which I sort of feel bad doing here at the end. But on the other hand, I mean, the point of reports like these and the work that we're gathered here to talk about is to affect change. And in this case, it's going to be necessary to do that through the political process. And so, in my experience, thinking about moving something like this from concept to reality and the strategic positioning necessary really comes down to essentially three things: focusing on the positives, accentuating the pieces that fit into the current political thinking of the day, identifying challenges in the environment that need to be addressed, and then starting to think creatively about remedies for those challenges. So I'm just going to give, and this is by no means an exhaustive list, and certainly others will have thoughts here, but just to sort of get the ball rolling, give a few thoughts on each of those. So as far as the positives and the kind of opportunities here, I think what is perhaps strongest is the fact that this report is grounded and really taps into what is now, I would argue, a real bipartisan consensus about the approach and the commitment that needs to be made to addressing our healthcare quality and cost problems and the fiscal ramifications of those through health system improvement, through migrating our current fragmented, siloed system towards an orientation around the triple aim. So that is something that at this point is agreed upon everywhere from the U.S. Chamber of Commerce to the Center for American Progress and everyone in between. It is certainly far superior to other options out there. And as Atul rightfully points out, the evidence is not overwhelming early on, but the fact is that both sides of the aisle are fully committed to pursuing this for at least the foreseeable future. And so the fact that this report would take strides and the potential outcomes would make strides in supporting that work, I think, is really important to highlight. Second is the very strong focus on accountability and transparency, which are, I think, increasingly over the years sort of foundational elements of legislation that's actually become enacted and implemented. And the third is that it certainly and clearly does not call for any major new investment of federal resources in a time when those are hard to come by, to say the least. So what are some of the challenges here? Well, the flip side of not calling for any significant investment is that the report also does not result in any significant budgetary savings, at least in the near term, over the next 10 years, which is as everyone in the room knows, is the kind of standard approach for the Congressional Budget Office these days. And the opportunity, I think, to enact legislation of this nature would almost certainly come in the foreseeable future in the context of some kind of a return to the idea of a grand bargain between both sides, in which the idea of improving and reforming entitlement programs and simultaneously putting them on a more sustainable fiscal trajectory would likely be the overarching goal. And so the idea of having some savings in the short term could very well have quite a bit of political currency. Now, that being said, I think that recent trends in both national health expenditures and Medicare and Medicaid projected growth growth has taken a little bit of that pressure off, though the recent NHE projections may take a little luster off of that argument. But there very well may be still a demand for scorable savings, and certainly that was not the intention of this report. The second is that these recommendations do have the potential for creating what is the only way to have a more toxic political environment than strong partisan fighting is geographic warfare. I mean, this, for those who followed the ACA closely, it's certainly being in the middle of it, it was the thing that kept me up at night the most, and on multiple occasions came extremely close to bringing the whole thing down. And so given the stated intention here of reducing geographic inequity and the crowd-pleasing comments of Bruce at the end, it gives you a sense that this is not going to be, would not be an easy cap to skin here. So come back to that. And then finally, certainly the new governance structures that are called for that have massive responsibility and significant access to federal funds do, I think, in my analysis, lack some meaningful accountability to Congress and to the public. And so those things, I think, would have to be addressed. Now, how do you start to tackle these things? Well, first, I think starting to collect data, fill information gaps through both private means and potentially, and here's a place where outside of the legislative process and potentially through regulation, administrative action, there may be ways to start collecting more data so that on the front end of a legislative push, you could create some more explicit outcome milestones, if you will, for the GME system to seek to produce over the time frame of, at least the foreseeable future, so that you start to have some framework beyond, these new committees being and councils being created and having some reporting mechanisms to actually having to meet some broad, flexible milestones so that we know whether we're moving forward. And then I think once you do that, just an initial thought here, but something to consider, does it at that point start to make sense to look at maybe budgetary ramifications not in the first 10 years but in the second decade? This has been a movement in CBO's scoring and analytical methodology, and that has had quite a bit of value, I think, in the legislative debate over the last 5 or 10 years, which is understanding the implications of these things in not just in the scorable budget window, but looking beyond that into the second, and what is the trajectory of that? And so I think you very well could consider augmenting these with potential cuts being triggered if some of these milestones are not met, as a way to ensure some accountability, and potentially also on the flip side, and it could be created in a more symmetrical way. Maybe it's creating some new resources if progress is being made. And if as conditions are evolving, and if new resources are needed, and those could come with some strong strings attached to them. But I think what this would produce would be an environment that would sort of keep people at the table and invested in this work. I think as Glenn was sort of alluding to, the fact that this discussion is pretty robust says a lot to the fact that there are these kind of impending threats of cuts coming, which makes you rethink whether the status quo really will be the sustainable course. And I think building in, and I know people hate these triggers, and they're a real pain to create, and no one likes them, but they do serve a purpose, and I think that's why you've seen them become more common, whether in legislation that's actually been enacted or in lots of the various proposals that have been bandied about. And then finally, I think as you start to think about some of these new resources, and this gets a little bit into the geographic fight. I mean, one way to alleviate a geographic fight is obviously to throw more money at the problem, but that does not necessarily present itself as a viable option here, but in the sense that there could be, through meeting benchmarks or something, some new resources. I think the key is to create, as level a playing field as possible, which in leveling that playing field very well could require a disproportionate amount of investment, maybe through the transformation fund, into those who stand to lose in this environment and may need more assistance than others in creating new models of training that would meet meet the desires and desired outcomes of the new system. And finally, just a few final thoughts here, perhaps apropos of nothing, but I think important in thinking about the move forward in kind of political context. I think this debate is sort of screaming out for a little bit of a broadening of the stakeholders that are involved. I think there are other very relevant impacted stakeholders that could and should have more to say here and be more visible. I would point to the employer community, for instance, another group that is certainly paying the bills. Obviously, it's all the consumer's money at the end of the day, but obviously the employers have a lot of near-term liabilities, and they are interested in purchasing a different type of healthcare product, as are other public and private purchasers. And so I think they have a stake in a future workforce that meets the needs for them financially and their ability to compete in the global marketplace and for their workers. And then finally, I think that there is an opportunity here to create some new information and some new terms, really, some new messaging in this area that would humanize this debate a little bit more and drill down into what this actually means for the quote unquote real people out there who may look at this and say, I would argue that the idea of moving to the triple aim is not something that has quite penetrated the public consciousness quite yet, and so there's a lot of work to do on that front. And similarly, in this vein, how can we really start to create a dialogue about what it means to individuals, families, caregivers, when the healthcare workforce is neither appropriate or sufficient to deliver three-part aim care. So I will stop there.
Thank you, Chris. We'll take about 10 minutes for questions. Chris, I'd ask you a question. You say, and I think you're right about this, the Congress is unlikely to take up GME short of a much broader discussion around entitlements in their future. But my question, and I obviously ask you to speculate here, what happens if the Republicans take control of the Senate in terms of the Finance Committee, the thinking there? It seems to have a rural orientation historically. What would you see coming in that regard?
Yeah, well, I think a broader point, and again, just for a minute, agnostically about the implications of what happens in the midterm election. But I think you could make a case that the a Republican-led Congress, president still in office, could start to create the conditions for eventually an attempt at some significant, not comprehensive, but significant legislative action. I think if you look back at the history of significant but incremental legislation, those things tend to come together when both sides feel like they have some investment and responsibility for governing. And at that point, that can create the conditions for neither side getting everything they want, but both feeling like, hey, we have to deliver here. And so I think that actually could help bring folks together. We'll see. As I said, I think that the Finance Committee has tended to be ground zero for some of these really tricky geographic issues, and I think that really that's going to call for some creative thinking, you would argue, for folks to get out ahead of that.
Mm-hmm. Glenn?
Excuse me. I just wanted to respond real quickly to Bruce's comment about the origin of IME. And I don't think there's any disagreement between us that the history was that the purpose of the IME adjustment was to pay for higher patient care costs associated with teaching activity. We fully agree on that. If the rationale is that, however, if that's the policy rationale for the payment, then it ought to be cut. Our evidence that we developed at MedPAC is that the current adjustment is multiples of the actual increase in patient costs attributable to teaching. What I hear, however, often is, well, it's not really about that. It's about supporting graduate medical education, or it's about supporting underfunded, desirable services that some institutions may provide. And my response to that is, okay, let's make it about GME, but let's make it really about GME and have accountability for using those dollars for that public purpose. Or if it's about other services that are not sufficiently provided, let's directly subsidize those activities, not just throw billions of dollars into the system, have it slosh around and hope some of it lands at the right place.
I don't disagree with you sort of analytically, and I think I said it in my remarks as well. And from the point, and I can't speak for any teaching hospitals, but I would just say the rational thing to do would be to reduce the IME to the empirically estimated amount where it should be now, and to raise the GME payments, which are supposed to be direct pass-through payments, to the actual costs that DGME now entails at institutions. And I think it turns out, from a dollar point of view, it's just about a wash, actually. Now, it won't be a wash at every particular institution, but I think the extent to which DGME is, direct graduate medical education, is now underpaid is not that far away from the extent to which IME empirically is overpaid.
Glenn, I think your point is well taken, and in an ideal world, we would make smart policies, but it's the same issue that I have with the IOM report in general, which is we don't live in an ideal world. And as soon as Congress gets a hold of this, what they'll say is, okay, we'll cut you here now, and we'll get around to paying you fairly for those services later sometime. Come back later. That's the way it works.
I just want to make one other point, that historically the only cut in IME was when I was in this.
So while Bruce can't speak for teaching hospitals, I guess I can. And I do think we have to keep in mind the limitations of the data that's available here in the public sector. So that while you're looking at year-to-year cost reports, we do use the cash flows off of IME and all the support that comes into a hospital to make capital investments. And this is a very capital-intensive industry, whether we're creating venues of care for education, or venues of care, venues of research, or venues of patient care in the clinical service world. And so today, right now today, we are making decisions that rely on those cash flows going forward. And so just looking at today's cost reports, or last year's or 2010 or 2011's cost data, or just looking in MedPAR, doesn't give you the whole story. And so I guess I would ask that as we evaluate GME, again, we not just look at the traditional sources of data that are available to us, but we actually need to go out and do a lot of case and field work to get a clearer picture of where the investment capital is going to be directed in the future.
Okay. Another question? Yes, ma'am. Mm-hmm.
Hi. My name is Marcy Nielsen. I'm at the Patient-Centered Primary Care Collaborative. I also serve as the first public member on the American Board of Family Medicine. And so I am interested in the public's role in all of this. I'd underscore Chris's point about the public doesn't really understand this. I should also point out I am from Kansas, getting a big wheat subsidy. And I don't entirely agree with all of Dr. Vladek's points, starting perhaps with this notion that, maybe we ought to be investing in malnourished seniors before we're investing more in the building of additional teaching hospitals and the medical industrial complex, and that's just a little tongue-in-cheek back for you. My question is...
I'm a great believer in food stamps. It was Senator Dole's proposal.
Indeed. But my question is, and it gets to a point that Atul was making and Chris was making, but I think the numbers that Glenn was talking about around IME, how are we going to bring the employer and the public into this conversation, which is very inside baseball? IME, when you look at what MedPAC has produced, we don't know where those dollars go. We haven't looked at the revenue side. We've looked at the cost side. It is going to be ripe for congressional picking. That's just the political reality. So how do we bring employers and the public into this conversation if, in fact, we think they're justifiable? And Atul and I have discussed this before.
You brought it up. Yeah, I mean, I think that
Both are, for different reasons, notoriously challenging groups to engage on these things. I mean, employers have any number of issues that they're facing in the policy sphere, health being a major one, but not the only one, and even within healthcare, just a lot going on, and it is very challenging to kind of elevate some of these issues up the priority. But I think that's why I was kind of making the point. I don't know the answer, but I feel like it's important enough to maybe think creatively with a group about, what are some of the kind of research initiatives here. I mean, I think that employers like the rest of us are more and more data-driven these days. How can we create some, essentially evidence basis for where some of the gaps in our workforce and training system are leading to very clear, definable gaps for them in terms of their employer health, productivity, and their cost trend.
I would just say also, Marcy, that one of the tough things is that as an employer, you want the lowest price for health care for your employees. As a patient, you want good care, but you also want least expensive care. There is an inherent responsibility of the government to invest in some of these things that maybe you can't ask individuals to invest in because it's too broad of a sense of, well, this really benefits me. Yes, I want the trauma center there, but I'm not using the trauma center today. Why should I pay for it?
Last question. Yes, sir.
Actually, if I could, I'm on the blind side of the room here. I've had my hand up a number of times. Two questions. One has to go with the science of really projecting workforce. And we recognize that healthcare delivery is changing.
And who are you again, please?
I'm sorry. My name is Dr. Bruce Sigsbee. I'm with the American Academy of Neurology. So first is the science of workforce projection. And how good is that? As not only are the way we deliver care, the venues, where it's delivered changing, but knowledge is just exploding. And in my own specialty, when I was in training, my mentors recently could know all of neurology. Right now, there are now 27 identified legitimate subspecialties of neurology. So, and this is just expanding. So is the science, and we talked about finely tuned pipelines, and is that really something that we can reasonably do? The second is, having read this report and looking at it, I come away with the sense that one of the overwhelming sort of basis for the report is, from the IOM, is that there's a certain political reality and new money just isn't going to happen, so that they really kept within current money. And I don't know if that's accurate or not, but if that's really the case, is that really the best analysis of GME going forward? And should we really be, putting something on the table that, as politics change, we can really look at? It was a very thoughtful, thorough analysis, but has it really constrained its recommendations because of political reality?
I'll just comment on the workforce projections. I've done that a little bit in the past. The problem with the workforce projections is that things are constantly moving. It's not perfect. We have an estimated shortage of 130,000 physicians or that equivalent of care. Is it right? No. I can tell you for sure. That's the only thing I know. It's not going to be absolutely right. But what we know is all the signs point in that direction of a relative shortage. I think increasing subspecialization, something that Dr. Sklar brought up, is a real problem. Back in 1960, we had 10 boarded specialties. We're at well over 145 now, and we can do a lot more, and we know a lot more. So as we increasingly see more patients with Parkinson's, with Alzheimer's, we're going to need you. And I think the best we can do is model. We should do it on a more regular basis. What we know is going to happen today and what the population is going to look like, where we've made the hugest errors is when we have assumed major, drastic, revolutionary changes like the one Steve brought up from 1985 that we're going to change the system forever.
Okay. Please join me in thanking the panel. And thank you all for coming.